are live now, ma'am.
Ma'am, I'm starting now.
I have some problem. Okay.
So good evening, everyone. A very warm welcome to all delegates and faculties of societies of Rajkot, Bhuj, Godhra, Behruch, and Jamnagar. Welcome to our series of webinar on obstetric hemorrhage, skill and drill. PPH, we all know, we have faced it. Almost everyone has faced it in our day-to-day lives, and it is really a nightmare. There were times when we had little to do during PPH. Either we gave uterotonics, we prayed to God, and if nothing worked, we went straight away for obstetric hysterectomies. But then now, over the years, we have developed so many good uterotonic drugs. Talking of carboprost, now we have carbetocin, which is giving really good results in patients and preventing patients of atonic PPH. Then before obstetric hysterectomies, we do have so many other things to do, be it bimanual compression or aortic compression. We have uterine balloon tamponade. We have the very beautiful SR cannula, for which sir will be showing us video today. We have so many devascularization procedures and internal iliac artery ligation. So there are so many things to do, and it is very important that we all should be aware of all these new developments. At least we should know one of the compression sutures, the tamponade or the SR cannula, and internal iliac ligation, so that during emergency, we are able to save the life of the patient. So this is the very aim of the key organizer of this webinar, Dr. Sadhana Gupta ma'am, her aim being knowledge is something to be shared. So before starting our scientific session, let's join hands and take blessings of Ma Saraswati, the goddess of knowledge. May Ma Saraswati ignite the darkness of ignorance with the light of knowledge. That was really very nice. Now it is my pride and pleasure to invite the key organizer of this webinar, a very hardcore clinician, a humble lady with leadership qualities, Dr. Sadhana Gupta ma'am. Madam is co-chair Suffolk NCD committee. She is FOXY representative to Suffolk. She was vice president FOXY 2016, ICOG governing council member, corresponding national editor and peer reviewer, Journal of Obs and Gynae and Journal of Suffolk.
It's okay.
Ma'am is a recipient of several awards, organized several conferences, CMEs, and she has been honored by several awards. And most important of all, she's the most deserving candidate for the post of president year 2023. A very warm welcome to you, ma'am, to address these societies and to invite and introduce Dr. Alpesh Gandhi, our chief guest of the evening.
Thank you, Babita. First of all, gratitude and warm welcome to Rajkot, Bhuj, Jamnagar, Godhra and Bharuch Society. So thank you all president and secretaries, Dr. Alpesh Patel, Dr. Chintan Thakkar, Dr. Hiralal Pandya, Dr. Sunil, Dr. Dhiren Pandey, Dr. Radha, Neeta, Varsha, Dr. Jignesh, Dr. Neeta and Dr. Prabha for making this happen, because actually that coordination between all of us is the thing why we are together. So a little bit before I introduce our chief guest about this series skill and drill PPH workshops, it is around 15th series which we are doing, and we are focusing on the video and the carry home skills transmission to all the obstetrician and gynecological societies of India, pan-India, so that everybody is confident in dealing with PPH whenever it comes to us. So with all the thanks for all the coordination and cooperation in this journey and our effort to save lives everywhere, it is a great pleasure to have none other than Dr. Alpesh Gandhi as a chief guest, who has been a personal mentor to me in my journey in Foxy and profession. He has been President Foxy 2020. He has been the legend in that time because that COVID crisis, and he has emerged what we are seeing today in this webinars and the skill and drill workshops. Actually, it was his courage and his perseverance with the COVID crisis that he is considered now the father of digitalization in Foxy. He has been a Vice President Foxy 2013, Governing Council member of ICOG, Chairperson Practical Obstetrical Committee with recipient of Best Committee Award, Vice President Gastrosys India Chapter, and he has been the past President and Secretary of Ahmedabad Society, Organizing Chair ICOG 2017, and past Joint Convener of the SAGOG, and the perfect organizer, and he has been a key figure in sensitizing obstetrician and gynecologists as well as the government of India for need of critical care, need of obstetrical SDU in our country, and we owe a lot to him for that maternal mortality and the criticality reduction in our country. Dr. Alpesh Gandhi has been one of the very, very important key figure who has reached not only to the leaders, to the government sector, but he has been reaching to all members of obstetrician gynecologists of pan-India, wherever they are. So, Dr. Alpesh Gandhi, it is a real pleasure to have you, and we request for your words of wisdom for the series and your vision for saving mothers. Dr. Alpesh.
Very good evening to all of you, and thank you very much, Dr. Sadhna ji, for the kind words and generous introduction, appreciating the work done by me. At the beginning, I would like to congratulate the Rajkot, Jamnagar, Bhuj, Godhra and Bharuch Society. આ એક બહુ સારું ઇનિશિયેટિવ છે. એકેડેમિક પ્રોગ્રામ, સોશિયલ પ્રોગ્રામ માટે સાથે મળી અને જોઈન્ટ પ્રોગ્રામ કરવાથી રીચ વધે છે, ઇફેક્ટ વધે છે અને ઘણી સારી ફેકલ્ટીઝ પણ આપણને બધાને મળી શકે છે. સો ધીસ ઇઝ વેરી ગુડ મૂવ and it is good that આના કારણે આપણું એક ફેલોશિપ પણ વધે છે. એકેડેમિકલી તો ડેફિનેટલી એક્સેલન્ટ થાય જ છે, આપણે ઇમ્પ્રૂવ કરીએ જ છે, પણ good work, joint work, team work is very, very important, and for that I would like to congratulate President, Secretary and societies of Rajkot, Jamnagar, Bhuj, Godhra and Bharuch. I would also like to thank Dr. Sadhna Gupta, who is the key organizer of this CME webinar, because of whom I could get this opportunity to meet all of you. In spite of without a physical visit of Rajkot, Jamnagar, Bhuj, Godhra and Bharuch Society, we could meet through this webinar. So thank you, Dr. Sadhna ji, for giving me this opportunity. I would also like to appreciate you for the work. I have seen you working in Foxy since last 25 years. I've seen you working from very grassroots level. I've seen you working on different positions in your local society as well as in Foxy, as well as in SAFOG and other organizations. I have seen you working as an organizer also. Every time I have seen you have done justice to all your positions and you have worked excellently. And I would like to appreciate that it is always saving mother is always in your heart and you are always working for it. I have read many articles and publications and you are always there in my all the projects whether it is for the high-risk pregnancy or critical care or a book, chapter in a book. So I know you very well, and I have seen you are a perfect qualification. We can say you are grassroots worker as well as you are leader. You have both the capacities and both the quality in you. So we have a lot of expectation from you, and my best wishes to you, Dr. Sadhna ji. Coming to our today's webinar on PPH, the topic is, I know it is very, very important, very relevant, and we all are very eager to listen all the experts, because we have many experts, many faculties across India. PPH is very important because about 830 women die from pregnancy or childbirth related complication around the world every day. Out of these, as per WHO, 25% of maternal deaths are because of PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 5 to 6% after cesarean section, with uterine atony being the cause in about 50% of the cases. And every year, about 14 million women around the world suffer from PPH. But the sad part is, in spite of so many technology, in spite of so good uterotonic drugs, everything, now we have so many things in our armamentarium to tackle PPH, the incidence of PPH is increasing day by day. Maybe because increasing incidence of obesity, maybe because of increasing incidence of previous cesarean section, placenta accreta, maybe because of pregnancy after ART, because of multiple pregnancy, maybe because of the elderly mother. So many reasons are there, maybe because of increased incidence of pre-eclampsia, eclampsia, or gestational diabetes mellitus. But whatever the reason, the incidence of PPH is increasing globally, and this is the sad part. So we need to update ourselves very, very regularly. Postpartum bleeding is the quickest of all the maternal, it is the quickest of maternal killers. It can kill even a healthy woman within a few hours if not treated. And these deaths have a major impact on the lives and health of the families affected. PPH is still in India is number 1 or 2 indication for obstetric HDU admission. It is in Western world, it may not be number 1 or 2 indication, but still in India, PPH and PIH are number 1 and 2 indications for the admission in obstetric HDU. It is always a nightmare for all of us, and it is not always predictable and preventable, but in many cases it can be preventable and predictable also. Severe anemia, home delivery, late referral, improper use of misoprostol, improper use of drugs, improper practice of blood transfusion, habit of smoking, this all add fuel on PPH. And simple measures like correction of anemia, control of hypertension, timely and proper use of injection tranexamic acid, balloon tamponade, compression suture, use of cannulas, timely reference, use of anti-pneumatic shock garments, proper blood transfusion practice. These small things can save many lives. Foxy has conducted many CMEs, many workshops since last few years. And it is our vision that no woman should die from any preventable disease and conditions. I would also like to give you a few simple tips which I have observed in my practice, and which I have observed that it is not performed at many places. Simple things. Always try to obtain past history of PPH in the previous pregnancy. Always try to identify whether the patient has low-lying placenta or not. We are asking for sonography for all the patients, but at the same time, we should ask, we should measure, or we should ask our radiologist friends to measure the distance between the lower margin of the placenta and the internal os of cervix. Always try to rule out placenta accreta in case of previous cesarean section during antenatal visit. Always try to know CBC, PT, APTT, platelet count before any obstetric surgery if it is not an emergency. Always keep cross-match blood ready before performing cesarean section. Optimization of incidence of LSCS is also very, very important because we know that incidence of cesarean section is very high, but in some part of India, it is still not available, this facility, and over trial are given. And because of this, also many problems are there. Always keep a long straight needle to perform jaw suture or right angle forceps and mixed-art for performing interiliac ligation. These all are simple things, but we should always keep this, our team and our setup ready to tackle this PPH. We appreciate your good work, and because of good work from all of us at individual level, at our society level, and at SOGOG level, now the maternal mortality rate in Gujarat is, it is said, it is nearly 45, 47. So I appreciate good work done by all the members of the SOGOG. We hope you will continue the same with same enthusiasm, and it is good that we all are discussing and updating ourselves for PPH, but let us decide that after certain years, after 4 or 5 years, we can make India free of death from any preventable causes like PPH. I really appreciate the time given by our expert faculty. So many expert faculty. I can see Dr. Varsha, Dr. Neeta, Dr. Sadhna Gupta, Dr. Nalini Misra, my friend Dr. Samartharam, Dr. Bhavik, Dr. Alpesh Patel, Dr. Chintan Thakkar, Dr. Babita Sukla, Dr. Naresh Bhanusali, Dr. Neeta Rada, Dr. Josna Suri, Dr. Siba, and panel discussion, Dr. Haresh Doshi, Dr. Jigna Ganatra, Dr. Prakash Parmar, Puneet Khatri, Divya, Dr. Hina Ben, Madam. So many are there, and I'm sure definitely we will have a wonderful webinar, very informative, useful webinar, which will help all of us in our routine practice. I wish grand success to this webinar, and once again, I congratulate Dr. Sadhna Gupta, and I request her to continue such webinars, such academic programs. Thank you very much for giving me this opportunity and inviting. Thanks a lot. Thank you.
Thank you, Dr. Alpesh. As always, you give always few key points which remind us that we have to do something today only in our labor room and operation theater. So thank you very much for your precious times and pulse of wisdom and your time also. So Dr. Babita, I think Dr. MC Patel will be joining us, so we can start.
I have joined.
Yes.
I have joined.
Good evening, Dr.
Patel. Good evening.
Yes, good evening.
So a great pleasure to have Dr. MC Patel. We are meeting Dr. Patel almost every weekends, and it is so good to sometimes meet at the webinar also. So he is a known medical legal savior of obstetrician and gynecologist in our fraternity. Whenever we are in trouble or our friends in the trouble, we call Dr. MC Patel. So in PPH, we say call for help. So after calling all the surgeon and the obstetrician anesthetic colleague, the second thought is of the Dr. MC Patel. So friends of friends, expert in his expertise of medical legal issues, Vice President Foxy 2018, Organizing Secretary ICOG 2017, remarkable chairperson Ethics and Medical Legal Committee, who has changed the face of Ethical Medical Legal Committee of Foxy in 2011 to 2013, and he has been honorary secretary-elect State Organization of Gynecologists and Obstetricians SOGOG, organizing chairperson MMCon 2018, and he has been honorary member and the president and the Ahmedabad Obs-Gynae Society, honorary member, National Managing Body, Indian Red Cross Society. He is doing a lot of social work like in remote areas for many programs, and we look forward to Dr. MC Patel for your words of wisdom, especially like putting on the medical legal aspect of postpartum hemorrhage as well. So welcome, Dr. Patel, once again, and we request for your words of blessings and the wishes for the webinar and for the subject.
Thank you, Dr. Sadhna, for kind words and for inviting me as a guest of honor to witness this very important webinar today, and you have very properly involved our good 5 societies of Gujarat, Bhuj, Rajkot, Jamnagar, Bharuch, and Godhra. And just Dr. Alpesh Gandhi was mentioning name of all, so I do not want to go for repetition. But PPH is very important topic, and as far as you mentioned about our medical legal part, this is our statistic of medical legal part, that almost 80% of total medical legal cases related to obstetrician and gynecology, they are related to obstetrician. And out of those 80%, it is related to lower segment cesarean section. And out of 80% of lower segment cesarean section complication, they are related to hemorrhage, whether antepartum, whether intrapartum, or whether postpartum. And it is very clear. So if you want to be safe 80% from medical legal problem, you will have to take care of hemorrhage and postpartum hemorrhage rather. So if you are well versed with the subject, how to manage, because in court of law, whenever you are facing any problem related to PPH, and usually we go with medical management, then surgical management, and as far as surgical management is concerned, conservative management, surgical management, and then ultimately obstetric hysterectomy is the last answer in few of the cases. But in any situation, patients or patient party are not mentally prepared to accept this situation, because ultimately they are interested in that ultimate outcome. And in a young patient, when hysterectomy is done, of course, to save life of patient in given situation, also becomes a potential area as far as litigation is concerned. Because in a very recent past, there was case from our own state of Gujarat, from Morbi. I was a medical legal counselor, and we won the case. Just judgment came 1 month back only. And it was the same case. It was very normal delivery and PPH. It was atonic PPH. She tried to manage by medical method. She went for blood product transfusion also. And ultimately, patient was shifted to Rajkot. And giving conservative treatment for half day or so. And ultimately, obstetric hysterectomy was done. And case was filed, and allegation was PPH was not prevented, and when there was PPH, it was not managed properly, and ultimately it led to hysterectomy. And in young age, she has lost her uterus. So this type of problem, as far as PPH part is concerned, is very common in our day-to-day practice as far as this era of CPA is concerned nowadays. But whenever we face this type of situation, our goal is to manage patient very nicely, meticulously, medical management or surgical management, if at all it is required, because ultimate goal is to save life of patient. And in court of law, it is always considered whatever you do to save life of patient is justified in court of law if you put all of your case in a best manner. So congratulations, Dr. Sadhana Gupta, for taking this very vital subject, PPH, for discussion, and inviting me to share my views and bless this webinar. So I bless this webinar, and I am quite hopeful it will be not only successful, but it will be very useful to all our delegates who have joined this webinar. Thank you very much.
Thank you, sir. Thanks a lot, because your support is our back end that makes us confident that you are with us and we can go ahead. And that case, because anyway, woman is more important than uterus, and you are there for us for the court of law. So both things go hand to hand, and we have to work together for all front. Dr. Alpesh, like for the all critical care need and SDU, we all the skills, all Nalini, Dr. Samartha, with all innovations Dr. Shashi is doing. So we all are together we have to be, and everybody increases everybody's confidence. So thank you very much once again. And Dr. Babita, you can go ahead with the scientific session.
So thank you so much, sir, for your pearls of wisdom. Without much ado, we quickly move towards a scientific session. Our first speaker today is none other than Dr. Sadhana Gupta ma'am. She'll be talking on resuscitation and medical management in PPH. For this session, I would like to invite our chairpersons, Dr. Varsha Hitesh Dhruv. Madam is president of Rajkot Obs and Gynae Society and senior gynecologist doing private practice since 1995. She is full-time gynecologist at Savarkundla Trust Hospital and worked as honorary gynecologist in many hospitals. Her area of interest being high-risk pregnancy and infertility. A very warm welcome to you, ma'am. Then we have Dr. Neeta Mandai Satar. She is organizing secretary, SOGOG 2019 Jamnagar, president of Jamnagar Obs and Gynae Society. She is ex-associate professor, Shri MP Shah Medical College Jamnagar, co-author of the book Textbook of Complications in Gynecological Surgery, published by Foxy. A very warm welcome to you, ma'am. Now I hand over the session to our chairpersons to conduct this session. I would request Dr. Varsha to introduce Sadhana ma'am and to conduct this session. Ma'am, unmute yourself. Unmute yourself, ma'am.
Yeah. Okay. Thank you, ma'am, for your kind introduction. Hello. Hello. Hello.
You
I'm
are audible, ma'am.
Okay.
You are audible.
Yeah. Okay. Thank you, ma'am, for your kind introduction. I'm very fortunate to introduce Dr. Sadhana, ma'am. As such, she doesn't need any introduction. Dr. Sadhana Gupta, ma'am, she is MBBS gold medalist, MS gold medalist, FICOG, FICMCH, FICMCU, co-chair SAFOG NCD committee, Foxy representative to SAFOG 2018 to 21, vice president Foxy 2016, ICOG governing council member 2015-2021 with best governing council award, corresponding national editor and peer reviewer of journal OBGY India and SAFOG, Foxy past chairperson, Foxy Safe Motherhood Committee, 3 times Korean Award winner for best scientific research paper, 4 times best AICOG research paper, sole author of book Cesarean Delivery, Vaginal Delivery, editor 7 Safe Motherhood Bulletin, ICOG Campus and Foxy Focus, awardee 3 times Dr. DC Datta Prize for the best Foxy publication, key organizer of national and international conference, Saving Mothers 2016-2019, honored at national and international forum for exemplary work done to reduce maternal mortality, recipient Dr. N.A. and Saina Pandit Award for Women Empowerment 2021, Economic Times Award for Service in COVID Times 2021, Director and Senior Consultant OBGY Jeevan Jyoti Hospital and Medical Research Center. Madam is our Foxy presidential candidate for election to year 2023. I hand over to Sadhana ma'am.
Welcome and
Neeta, you are unmuted. Yes.
yeah. Welcome and best wishes, Dr. Sadhana, for your next tenure.
Thank you. Thank you. Thank you, Dr. Varsha and Dr. Neeta, for kind introduction. And again, I sincerely thank Rajkot, Bhuj, Jamnagar, Godhra and Bharuch Society for making this happening. So we are together. So I'm sharing my screen. I will be very basic and what is needed. And if we do this first step good and like in a very coordinated manner, sometimes we really don't need to go for the other measures. So सभी को नवरात्रि की शुभकामनाएं। बहुत शुभ दिन पे हम लोग साथ हैं और हम हमेशा शक्ति और विद्या को पाएं, इसी कामना के साथ। And I owe a big gratitude for being together. And what I am today with Dr. Lalpesh and Dr. MC Patel's presence, the Gujarat has made it what I am today, because we got guidance right from Dr. Behram and Glyceria and Pankaj Desai, that we learned so many things for the professional, how to work with the professional body as well as the personal life. So a big gratitude to Gujarat. And I bring greeting from the land of Buddha, and we have to be with this point that we can never obtain peace in the outer world until we make peace with the ourselves. So PPH, Dr. Alpesh has already set the stage, and Dr. Patel, that how common it is, and it is contributing still to 25 to 30% of all maternal death worldwide, and more so in our developing countries. The clinician perspective, because the global statistics might not attract us, but for the clinician perspective, it is going to happen in 2 to 10% of all deliveries we are going to face. So no escape from the postpartum hemorrhage for varying severity, and 1 out of 1,000 can be massive and life-threatening. Without aggressive management, PPH can rapidly worsen and lead to hypovolemic shock, organ failure, and death. And that's why we are together today, because we need the aggressive approach. It is a cause of long-term severe morbidity, and all hysterectomy, ICU admission, massive blood transfusion are classified in the category of the near miss and the severe acute maternal morbidity. So in India, it is contributing to 35 to 56% of the maternal death. And again, the clinician and the system perspective is that PPH tests the functioning of health system. It tests skill of health worker. It tests our guts. It tests our personality. It tests our leadership. Often unpredicted, presented like a thunderbolt, and we know tone, tissue, trauma, thrombin are there, adding on to new upcoming things. But important thing that we can lose the patient rapidly. It is the most rapid killer and most rapid cause of the maternal criticality. So we have all age-old problem, anemia, 3 delays. It has not gone out of our system, because even in one state or one country, we have the regional difference. But the new challenges, what Dr. Patel was, Dr. Alpesh Gandhi was pointing out, that if we are more cesarean section, more placenta percreta, more IVF pregnancies, and more comorbidities, and the patient is taking a lot of drugs, and that makes the PPH management sometimes very, very complex, because we are not ready for it. Our textbook is not talking about it. So what we want in this today, next 1.5 hour, we want to prevent life-threatening PPH. We want to make a very clear mind map that how to make a quick decision among chaos, confusion, and complexity. And when we manage, we know that when we manage PPH with success, it is a moral booster. But if we lose the patient, it is a lifetime scar on heart of obstetrician. They are demoralized, sometimes media issue, we leave obstetrical practice. And here is the thing where the issue of mental health for our doctors is also very, very important. If we do suboptimal, if we are not aggressive, it is the condition where we need a really proactive approach in prophylaxis as well as management, because implications are huge. It is for mother, neonatal, obstetrician, and medico-legal, and media and social issue. So all 3 delays, we are fortunate that now our government is doing so much for the health and so much more for the women health. And when I was just in the Jorhat in Northeast, it was great that I saw the water ambulance and one person coming from the Migachi to coming to Jorhat Medical College. So our responsibility is now at the 3rd delay at the tertiary facility. So we will go one by one. Prevention, that is the best thing what we can offer to our patient, and always look for the risk factor. So history of postpartum hemorrhage, all placenta previous, all previous operative deliveries, and all pre-existing bleeding disorder, and treatment with anticoagulant, which sometimes we are giving. Now the aspirin and heparin we are giving for so many reasons, and that adds to the postpartum hemorrhage. Important thing in our system when we identify risk factor, because we are very good clinician, but patient might be coming to emergency at any PSC, any place where. So flash all these risk factor on the antenatal card. Always counsel family for the PPH risk and the risk like need for the blood transfusion, and sometimes the delivery at the delivery plan, that is the micro delivery plan and the macro delivery plan, so that the family is ready and they are not unaware, caught in certain situation when they are not able to go for the good treatment for the cost or for the availability issue. So for active management of third stage of labor, so we have come a long way. And now the most important arm of active management of third stage of the labor is the oxytocin agent within 1 minute of birth of the baby, and the control contraction with the bar that the skilled birth attendant should be there, and uterine massage not recommended. So we have come to very, very practical active management of third stage of labor by WHO, and it has all the advantage: reduce third stage, reduce PPH, severity of PPH anemia, and the need of other uterotonic and the blood transfusion. So oxytocin 10 unit intramuscular or IV in the fluid is the thing which we used to do, because there were no contraindication for oxytocin, and it is a good uterine contraction and almost no effect on the maternal hemodynamic status, especially with the IM approach. So misoprostol always remains the second choice. So I want to emphasize just few important points to August audience, that misoprostol is not a first choice for the active management of third stage of labor. It is second choice when the drug is not available. Paramedical infrastructure issue is there, and it can be associated with shivering, vomiting, diarrhea, and pyrexia, that we must know, and a little bit of question mark that how far it is good in when the maternal condition is unstable. So active management of third stage of labor, and with the availability of carbetocin, there has been the paradigm shift, because it is a long-acting oxytocin and it is a room-stable oxytocin. So our women and ourselves have waited long for this drug, which came in India after Champion trial, where the India contributed very, very strongly. And it is a drug of choice now for the active management of third stage of labor for cesarean delivery, as well as the vaginal delivery, if it is available and if it is affordable. And I say that today our women are so empowered that the 400 or 350 rupees drug should be affordable and should be available for our all women, because advantage are huge, and especially the issue of cold storage, which is there with the oxytocin. So it is a long acting. So once it is there, you can avoid the 1 hour oxytocin infusion. So overall, it is a good economically, also it is a good option for the active management of third stage of labor. So what is important, that we know the subject, we know the risk factor, but it should be available, it should be flashed, and it should be known to everyone. And we know the drugs, but drugs should be available with a good cold chain provision whenever the drug is needed, and the quality paramedical worker who know what to give them. So that is the thing, that the first and forearm is the oxytocin administration. Now coming to the management, that what we should do, because more you sweat in peace, less you bleed in war, because PPH is going to happen even sometimes with the AMTSL, and we have to be ready with our drills. Why do mothers become critical or die? Because there is a delay in correction of hypovolemia. It is not that aggressive and enthusiastic, and delay in control of bleeding. So we have to be ready with the golden hour, which is birth, golden second every point, and in golden hour. So one message, that never shift, despite the loads of the labor room, never shift the patient before 2 hours to the postnatal ward. And in this golden hour, our nurses have to watch for the bleeding, height of uterus, vitals, level of alertness, and the oxygen saturation. PPH can be primary as well as the secondary. We have around 6% after cesarean section. And whenever any obstetrician got the call that this patient is having bleeding, first of all, you go there, make quick 360-degree view. You might not be there during vaginal delivery. You might not be there. You may be the second opinion. So take 360-degree view while we are resuscitating initial management, because cause analysis should be in our mind. Tone tissue trauma thrombin, we know as a MBBS, as a consultant, important thing is in 360-degree view that you take that for this patient, what were the risk factor. If she was the prom, she was using tocolytic, she was having the uterine abnormality, more chances of atony. If the difficult delivery, there was a delay in placenta or the previous cesarean section, then tissue. And if it has been the operative or a large size baby, then trauma. So that 360-degree round is important, so that we have a quick cause analysis that in this patient, I'm going to focus on it and I have to look on it. So that is very, very important. And always, whenever there is a IUFD, intrauterine fetal death, preeclampsia, we have to look for the coagulopathy, because tone tissue trauma, we have been talking a lot and many obstetricians and our nurses are aware of it. But coagulopathies are there where still there is a knowledge gap, and we have to be very, very careful how to do the coagulation parameter and how to deal with it. So atonic hemorrhage, again 70% maximum, followed by trauma, followed by retained product, and 1% for the thrombin. And you should, it is never always, so many times there is a multiple cause. So from it can lead to infection, sepsis leads to atony. We are using Maxulf, we are using Difadipine in case of preeclampsia, and that caused the monstrous combination for atonicity, for the a little bit coagulopathy, because we are giving aspirin also. So a lot of drugs we are using for high risk situation, they are good, but they also increase the chance for the postpartum hemorrhage. So this is very important, and we have to be, the second thing in golden hour, that we cannot wait for the blood pressure to go down and pulse to get very high, because physiologically the pregnant woman has been the hypervolemic, and when there is a around 500 to 700 ml blood loss, there is no change in the pulse and blood pressure, and that's why we have to be very, very careful in estimating the heart rate, which we are just dealing with it. Good training for the visual estimation of blood loss is very, very important. We are doing Manyata training. We are reaching to peripheries, even the rural nursing homes, and we are talking and we are training them how to make a good, like, estimation of the visible estimation of blood loss. And I will say, give clear instruction to labor room staff. That is 5 soap. If there are 5 soap normal size bag, 1 soap big sanitary napkin, continuous trickle of blood, that is very dicey. We can use something instead. Dr. Nalini is going to like deal with some self-made bag instant at the site. We can make that estimation bag, and altering woman's condition. So this is important. And when there is PPH, even for mild PPH, you call your friends, because we never know that this mild PPH is going to result into moderate or the severe. So always look, it is airway, breathing, circulation, quick analysis of amount of bleeding, and quick analysis of the cause. We have to look for the pulse, blood pressure, tissue perfusion, that is capillary refilling, and the urinary output, which tells about the organ perfusion. Shock index is very, very doable thing. Just it is that the cardiac monitor should be available in our labor room also, so that we can use this. If it is a more than 1, then it is a really worrisome. If it is less than 1, we have the time. So these are the simple things, classical teaching, important thing that we have to utilize. This should be in our hardcore, not only in our hardcore, but our resident as well as the junior nursing staff. We have to be ready with drug, oxygen cylinder, emergency tray for PPH, chart for PPH, and we have done a lot of work. And I think now most of the facilities are having all these emergency trays and the PPH and all the drugs available for this. So basic EMOC is the replace fluid, arrest bleeding, send blood for the cross match, catheter, alert consultant obstetrician on call, give antibiotic, and record event and the communicate. In any situation, we have to have the verbal as well as the written communication, especially in postpartum hemorrhage. So allocate one person who is good in counseling and who can take the signature and everything. Whenever there is a blood loss, higher blood loss more than around 1000, you have to be ready with all aggressive measure for the resuscitation. That is airway, breathing, circulation. Now at this point, even if oxygen saturation is okay, we should give oxygen around 8 to 10 liter per minute, and always give the 2 IV cannula, and that should be either gray or green. So never put pink cannula, IV cannula to any laboring woman or any woman for cesarean section, because if we need more fluid, then pink cannula is going to deceive us. So green or gray cannula, and we can start like that. Is the crystalloid is our something which gives lives to the patient, and the hemaxil or the plasma expander or the colloids are the second choice, and always ready with your medical drug. So all aortic compression we will be covering in the video. So resuscitate, investigate, monitor, communicate, and record keeping. At this same time, we must have in our PPH box all these vial, plain vials, EDTA vial, and the citrated vial for the coagulation, for the renal function, and for the hematogram test. So once you are putting the second IV line, at that time we should take blood for all the investigation. That is very, very important. A word about the PPH bundle care, and as a Foxy presidential candidate, I owe that like adopting all bundle cares, we are going to like bridging the gaps in the maternal health care, and they are set of intervention, and it is a uterotonic drug, crystalloid, tranexamic acid, and then the second line measure, which we are going to deal in the next session. So this is all, and for 1 liter, you have to give 2.5 liter or 3 liter of the crystalloid. Crystalloid is the thing which we want because it rapidly accumulate between extravascular and intravascular space, so there is less chance of any pulmonary edema, and beside the colloid also disturb into the coagulation parameters. So it is ringer lactate and normal saline, and you can give around 2000 ml. You have to ask always right question: what is the 360-degree round? Is placenta delivered? If it is complete. So always tell your nurses and the guys that keep placenta till golden hour is complete, that for 2 hours. So if the patient start bleeding after half an hour or after 1 hour, you are there to make ensure that this placenta is complete. If it is not complete, we have to mobilize for the MRP. And if there is suspicion of PAS, that is the placenta accreta spectrum disorder, no attempt to remove the placenta, but go for the operative measure. So catheterize, bundle massage, that is the like our obstetrical art, how to do the massage in the circular fashion, and clean all vaginal clot through the vagina. So that cleaning gives you the uterine contraction, and you also know sometimes patient is not passing blood outside, but when you see, especially in after cesarean section, when you do the pervaginum, you find that the vagina is full of blood. So always clean the vaginal clot from the vaginal clots. So oxytocin, carbetocin, methyl ergometrin, misoprostol, prostaglandin, these are our uterotonic drugs. Important thing is right storage and the right use of drug. So don't give, like we can use the 5 injection of methyl ergometrin, 8 injection of prostaglandin F2 alpha, and misoprostol 600 to 1000 microgram. So important thing is that don't do the half-hearted medical management. That's why if you give the full dose so many times, you don't need to resort to surgical measure, and always know what are the contraindication of that particular drug, especially methyl ergometrin, where the hypertension, severe anemia, and cardiac disease, all these are contraindication, and we have to resort to the PGF2 alpha. So right dose, right storage, and the optimum use. One drug has failed, then the second drug will be effective. So if you have given carbetocin as active management of third stage of labor, oxytocin might not work because carbetocin is like fulfilling all oxytocin receptor. If you have given oxytocin for induction of labor, oxytocin might not work and you have to go for the methyl ergometry on the PGF2 alpha. So one by one, don't really believe only one favorite drug. Don't choose your favorite, be equal, and you can use the first and second and third line of the drugs. So this is very, very important, that optimum dose and the optimum refrigeration. However, if you have done 3 doses of methyl ergometry or PGF2 alpha, then we must start thinking of doing adjuvant measure, that is a conservative surgical measure, or taking the patient to the operation theater. Tranexamic acid after women's trial has come, and WHO recommended that it should be given in prophylactically in all high risk as a early measure in the management of postpartum hemorrhage, and the next dose within 3 hours. And after 3 hours of the postpartum hemorrhage, actually it is not going to help. It might cause harm also. So this is important thing, that tranexamic acid has come to our armamentarium. All professional body recommended, and I want very, very important. These are in our National Medical Council, as well as these are the papers, right, 2020 from the anesthetists from the Western world as well, that tranexamic acid has been inadvertently given for the neuroaxial anesthesia because it resembles with the bupivacaine. So very, very important. It causes mortality, severe criticality. So with all the things, I suggest that keep one magnifying glass also in the operation theater, so that we don't put into a sudden and unexpected problems. So blood transfusion, when to use? Whenever there is a moderate to severe PPH or hemoglobin is less than 7 grams. And I suggest that we should have this HemoQ method, or any quick method which we can do at the bedside hemoglobin, because when we are in trouble, especially if there is an internal bleeding, or sometimes we want to, the patient is not having no attendant for giving blood donation, that is the time that this hemoglobin test quick gives you the quickest answer, that what is the condition of the patient and how much is the need of the blood transfusion. There can be significant fall in fibrinogen level, that is the coagulopathy, and these are all predisposing condition. Important thing that always highlight that these are the predisposing condition, because DIC is considered diagnostic only when there is a predisposing obstetrical condition. Bedside test, still bedside HemoQ test and bedside coagulation test, still they are relevant, because fibrinogen test might take around half an hour to do, but you can do very, very simply all these tests. So this is important. Massive blood transfusion protocol start after 4 or 5 units of blood. So this is important, because we are having so many webinars, and sometimes people right from the very beginning start 1:1, 1:1. So that start after 4 or 5 unit of the PRBC. These are our target after blood transfusion: hemoglobin more than 8, platelet count 75 lakh, prothrombin less than 1.5, and fibrinogen more than 1.0. Always be ready with all PPH tray and the trolleys. This is very, very important, and we always record, event, communicate, because every patient of the PPH is a potentially medico-legal. So I will say, join Manyata. Our center is skilled, and right in the presidential tenure of Dr. Alpesh Gandhi, our hospital has been recognized as a center of skill enhancement. So we can use this advantage, and always treat the cause to retain placenta MRP inversion. Again, the issue we will take into the panel, and the laceration. I will not go into the conservative. This time putting that we are always propagating Samartharam cannula everywhere, because we have found very, very good experience all over the country. When to patient to shift patient to OT. So whenever if you have to explore, you have to shift into OT. We have the good technique, good anesthetist, and the transvaginal uterine artery clamp. This I want to say, very, very good innovation by our own Dr. VP Pelli, and you can shift the patient to OT at that time, and it really works well in the reduction of PPH with very good standard, with very good survival rate, and the reduction into hemorrhage. Retain placenta, important thing, that mobilize the team for MRP at your earliest, because Iron Donor says the real difficult part about MRP is the decision to undertake it. So don't delay it. So this is all. So when to time to open up for the laparotomy, profuse bleeding, unstable vital, indefinite contour of uterus, lump felt perabdominally. This is time to open the patient. So we are not going. So coming to last, we have to save lives, and this is a drastic situation which need aggressive measure. Set the protocol and take swift by decision, and get ready with your team. Prepare team of friends. So friends are the things which we need all over life for everything. And when the patient need hysterectomy, it should be done at the right time and not at that time when the patient is in irreversible shock. So finally, you can fill the unforgiving minute with 60 seconds worth of distance. Run, run, run. It is all about PPH. And with this, I see your full-hearted support for my Foxy presidential candidature. I am ready with my vision. And with your great expertise, Gujarat has put a landmark. It is around 45 maternal mortality rate. You have so much to give to our federation and our country, and we look forward for working together. Thank you very much.
I would request the chairpersons to give their input on the talk. It was really very comprehensive, covering every aspect of PPH. Only Madam can do it. So, Dr. Varsha, ma'am, are you there? Yes.
Yeah. Yes. Madam said everything very right. We should be always ready for any worst situation. Thank you, ma'am. Thank you for your very informative talk. And we all support. We are ready to support you. And as a president, we want to see you as a president of Foxy. Thank
Yes,
you.
we would like input of Dr. Neeta Mandai also. Ma'am, are you there? Dr. Neeta? I can see her name.
She was there.
Okay. Dr. Neeta.
She told me that she is out of station, and there may be the net issue might be there.
So let's quickly move on to the next session. We have 3 very interesting video sessions by Dr. Nalini Mishra, Dr. Samarth Ram, and Dr. Shashi Kabra ma'am. So first video session is by Dr. Nalini Mishra, Uterine Balloon Tamponade, for which I would like to invite our chairpersons, Dr. Chintan Thakkar. Sir is president of Behruch Obs and Gynae Society. He has worked as superintendent CSC, Balasinor for 2 years, worked as gynecologist at Trust Hospital for 3 years. Now, sir is in private practice. He is in government panel of laparoscopic surgeons since last 19 years. He has joined many community projects, educational webinars, and public awareness programs. His key areas of interest being laparoscopy and infertility. A very warm welcome to you, sir. And Dr. Alpesh Patel is secretary of Godhra Obs and Gynae Society. Sir is consultant at Navjeevan Nursing Home, Godhra. So very warm welcome to our chairpersons. And I would request Dr. Alpesh sir to introduce Nalini ma'am. Dr. Alpesh sir is there.
Yeah, good evening, everybody. Am I audible?
Yes, sir. Yes, sir.
Yes. I would like to welcome Dr. Nalini Mishra, madam. She is MD, DGO, DNB, FICOG, Dean and Professor, Allen Medical College and JK Super Speciality Hospital, Bhopal. Innovation to credit, CG balloon, innovation low cost uterine balloon tamponade, G drape, innovative low cost drape for estimating blood loss at the delivery, and innovative low cost concept to rationalize the transfusion of blood products in the PPH. Invited faculties in conferences more than 150s. She has a publications in more than 50s and citations in more than 150s. I would invite for her video. We have a video presentation of Dr. Nalini madam.
Ma'am, shall I share your video? You'll try it yourself.
No. You
Okay.
share my video.
Okay.
And thank you, Dr. Patel, for kind words. Thank you, Sadhana Madam, for giving me the chance. Babita, please.
Yes, ma'am. Yes, ma'am.
Namaskar. I am Dr. Nalini Mishra from Bhopal. So, whenever there is a diagnosis of PPH, we have to go for the PPH care bundle as already been discussed. So, the first response bundle is contains 4 components, that is uterine massage, oxytocin, tranexamic acid, and isotonic crystalloid, preferably ringer. So, we can remember it by MOTIV, M-O-T-I-V. Now then, and we have instituted the first line management, then we have to go for the second line intervention. And the second line intervention are covered under the refractory PPH bundle of WHO Technical Committee. So it comprises 2 compressions and 2 devices. So the 2 compressions are manual aortic compression and manual uterine compression. Then the 2 devices are intrauterine balloon tamponade device and non-pneumatic anti-shock garment. There are many varieties of uterine balloon tamponade, and there are some commercial ones which are available, but they are costly and not available everywhere. So I will be describing the Chhattisgarh balloon, and how do we make this Chhattisgarh balloon is we need certain things, and we have to prepare it at the point of care. It's not a commercial device, so we need certain things, and for that it is very important that we have the Foley's catheter of at least 22 French or 20 French in our basket of PPH, and then there should be condoms, then there should be 2 syringes of 20 ml preferably, if not available then even 10 ml will do. There should be 2 big speculums, sponge holding forceps, Eurosec catheter, gloves, and of course the scissors and normal saline. How do we make the CG balloon? We remember through these stages of A to F. So what is A? A is for air. So we instill at least 10 to 15 cc of air through the bulb inflation port into the bulb of the Foley's catheter. Then we just put it round our index finger of the left hand and burst the bulb of the Foley's catheter. So once it is perforated, insert the scissors into it and just cut it circumferentially all around the shaft of the Foley's catheter. Then the upper flap is everted upwards and the lower flap is brought downwards. The purpose is to expose the hole on the shaft of the bulb. Then comes the B, or making the bulb. So the condom is rolled over the proximal 1/3 of the Foley's catheter, and with the other hand we keep it at the tip. So the C is cutting the 2 rings from the urinary drainage port of the Foley's catheter. You can see we prepare 1 millimeter
should I speak?
thick ring, and first ring is applied. So D is for double application. First ring is applied at
yes,
neck.
kuch na,
You see that we have
because
prepared a neck at the side, at the junction catheter as well as the tip
Should
of
I
the
speak,
catheter.
Babita?
So you apply first ring, winding it around twice, double application, and then it is snugly fitted. The second ring is applied on the lower portion of the condom, 1.5 centimeters away from the rim of the condom. We have to take care that this does not wobble. This should remain straight. Then cut. E is for excision, excise the tip of the condom and tip of the catheter together. There is a hole at the top. Then this creates a drainage port. Now put it in the betadine solution for 3 minutes and cut open a bottle of normal saline. In winters, warm it, This is the CG drip which is depicting that it has bled more than 1 liter, and now the cervix is exposed with the help of 2 big speculums and with the help of caught with the help of 2 sponge holding forceps. Now this CG balloon is taken into between the 2 fingers, and it is introduced in the uterus. Being having a conical apex, it goes easily, nicely it goes in till the rim of the condom is visible at the level of the internal os. If you want, you can put it even above that. This is done. Now after that, we have to pack the vagina. This is the biggest advantage of Chhattisgarh balloon, that we can pack the vagina before inflating the bulb, because we are seeing the ongoing bleeding through the in the urosec, tubing of the urosec, which we have connected to the urinary drainage port. Now we have to inflate the bulb. So take 2 syringes while one is inflating the bulb, the other person is filling the syringe, and this way we keep inflating till we feel the resistance in inflation, and the column of the blood which we can see, which we now see in the tubing of the urosec, it stops moving. So whenever the bleeding is less than 50 ml per hour, or within less than 1 ml per minute roughly, so we can say that the hemostasis is achieved. Then the woman is catheterized, the uterine margins are drip and on antibiotic. Now if you want, you can prepare the Chhattisgarh balloon in advance and get it ETO'd and keep it in your labor room. You can deflate it 6 to 24 hours later, and for deflating, I prefer that we put a needle in the bulb inflation port, and then slowly it drains out, and then when we take out the pack, the drape balloon comes out after that. So if there is recurrence before taking out the pack, we can re-inflate, but generally I never needed to. If one is not free, you could not prepare it in advance and you are forgetting the steps, you can make a more simpler one, and that is easy balloon. So that is very, very easy. As you can see, we cut the 2 rings from the Foley's urinary drainage area and roll the condom on the proximal 1/3 of the catheter now, and you fasten it with the help of the ring which we have prepared already. So twice only, and we are not creating a drainage port here, so even staff nurses can make and use it. So this is done simply. We prepare it. We can prepare it within 10 seconds. And then again the cervix is exposed using 2 big speculums, and both lips of the cervix are caught with the help of these 2 sponge holding forceps, and then this is simply taken, and this easy balloon is more like a conventional condom balloon tamponade, only changes the way of fastening, which we have done by 2 rings cutting from the urinary drainage port. So we do not use any suture material. The principle is same. It is inserted till the rim is visible at the level of the os, and then here we cannot pack it. That is the disadvantage. And but here the advantage is that we can instill the fluid directly through the with the help of an IV set and the normal saline easily, and then the lower portion is folded once the hemostasis is achieved, and the second ring is taken, and we have to wound it round 3 times. This is the difference. This is 3 times. We just have to do it so that the saline doesn't come out, and rest of the precautions are same. And then when we have to deflate it 6 to 24 hours later, when the woman is settled, whenever we have to deflate, you just have to pull open the 2 ends and the saline comes out. So this is easy balloon. When we talk of Chhattisgarh drape, CG balloon or easy balloon, These are all our local innovations and can be prepared at the point of care. There's nothing commercial about it. So I really feel very proud to be an Indian, and I thank you so much.
Was it audible?
Yes, ma'am. Now it's on.
Okay. Okay. So I would request the chairpersons to give their comments.
Share the screen.
Person's comment. Okay.
Dr. Chintan and Dr. Alpesh Patel, kindly give your comments.
No. Hey, screen share.
Hello.
So
It is-
please wait, sir. Comments are going on. Chairperson's comments.
Yes.
Hello. It's a very useful and easily available technique for day-to-day use. Every setup.
So please unmute yourself. Yes.
Sorry. Sorry. It's very useful in day-to-day. Even it's useful in a very tribal area where other no facility is available. So it can be very good tool to have a management of such sort of management in PPH. Thank you very much.
Thank you so much, sir. So we quickly move over to our next session. Our speaker is Dr. Samarth Ram, and I would like to invite our chairpersons for this session, Dr. Bhavik Khatri
Share
and
screen.
myself. Sir, are you there? Dr. Bhavik,
There.
kindly introduce Dr. Samarth Ram.
Yes, madam.
Okay.
Dr. Samarth Ram, sir, is the winner of prestigious senior category Foxy Korean Award. He has also awarded Foxy Figo Award and K4G President Gold Medal and Yuva Foxy Award. His PPH suction cannula and oral hydration therapy to prevent severe pulmonary embolism could bring down MMR very significantly in Kerala, Andhra Pradesh, and Tamil Nadu. He has got multiple publications. And over to you, Samarth Ram, sir.
Thank you very much. Screen, share the screen. Hey, voice. I'm able to, hey, they are able to hear me?
Yes, sir.
Yes, sir.
Yes, sir.
1 minute. What is this? Hey, I think I'm clear now.
Yes, sir.
Yeah, just put it like this somewhere. Good evening. Good evening, chairpersons, and good evening, everybody.
Good evening,
Very much thankful to Dr. Sadhana Gupta ji for giving me this opportunity. She's a very nice woman, very kind-hearted, and very able and very brilliant. I wish her best of luck in the coming Foxy presidential election. Before I go to show my videos, I would like to share some vital information about SRPP cannula. Move on. Atonic postpartum hemorrhage is the leading cause of maternal death all over the world, amounting to 28%. SRPP suction cannula is an accepted modality for treating and preventing atonic PPH in entire South India. Entire Kerala, entire Tamil Nadu, over 80% of Andhra Pradesh, and many major hospitals in Karnataka are using this instrument to treat and prevent PPH. Kerala Federation of Obstetrics and Gynecology had included this device in its obstetric protocols to prevent and treat PPH. Humpty number of dissertations are going on at different medical colleges in the country on this device. 3 RCTs are going on at Agra, Chennai, and Cochin. If you observe the MMR report by Government of India very recently, about 2017-19 and 18-20, you can see a drastic reduction in MMR in southern states like Andhra Pradesh, Telangana, and Karnataka. In Andhra Pradesh, there is a reduction of 22%, and Telangana it is 23%, and in Karnataka 16%, and 36% reduction in MMR in this 1 year, 1.5 years, 2 years time in Kerala. The lowest maternal mortality recorded in the country is in 19, that is in Kerala. No time before this so low MMR was recorded in Kerala. This major reduction in MMR in South India is mainly due to introduction of SR cannula for the management of atonic postpartum hemorrhage. When you think about see the results of MMR in North India, you can see alarming high MMR, Assam 195, Bihar 118, Madhya Pradesh 173, like this, very high. No reduction is there in any recent past of the times. So there's every need to introduce this suction cannula for the postpartum hemorrhage in North India. Myself and Dr. Sharada Gupta ji, and we are struggling hard to introduce this device in North India. This is SRPP suction cannula which I have developed, measures 23 centimeters long, fundal portion, cervical portion, this is vaginal portion. This is the nipple of the cannula which stays outside to be connected to the suction machine through tubing to create negative pressure inside the uterine cavity. The mechanism, how it works, this is atonic flabby uterus bleeding, cannula inserted here. When negative pressure applied, the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Uterus becomes a closed cavity. Further continuation of negative pressure results in constriction, contraction, and firm retraction of uterus on the surface of the cannula, which assists the natural physiological process of contraction and retraction to stop atonic bleeding. This is the uterus I am showing here. Inside the cannula is working and creating a powerful global constriction of the uterus because of the powerful negative pressure inside. It is 650 millimeters of mercury. You can see it is not the rugosity. You can see the coarse ridges on the entire surface of the uterus, both upper segment and lower segment. This is the reason why cannula is very effective to stop bleeding in lower segment, even in case of placenta previa. 5 different sizes of cannulas are made, different cervical dilatations to match different cervical dilatations and different uterocervical lengths. Why we need different sizes of cannulas? Different obstetric bleeding situations have different cervical dilatations and different uterocervical lengths. These are the cannulas designed for atonic PPH after vaginal delivery. Thin cannula is for not well dilated cervix. This is the size cannula for application after vaginal delivery. These are the APU and lateral view, and these are the cannulas designed for atonic PPH during cesarean section. And this is the thin cannula meant for cervix admitting one finger. This is the cannula with a 1.8 centimeters diameter and used for dilated cervix for atonic PPH during cesarean section. And this is the cannula designed for bleeding after MTP or vesicular molar extraction. This cannula is also used as a suction tube introducer while doing cesarean section. SR cannula application for atonic PPH during vaginal delivery. I am showing a video here.
Woman bleeding profusely. Vagina retracted with white blood speck like this. 5 centimeters of anterior cervix is caught with the sponge holding forceps like this. Cannula inserted. Tip of the cannula should be at the level of fundus and should be felt bimanually. Nipple of the cannula should be connected to the suction machine through tubing. Negative pressure should be applied. A negative pressure of 650 millimeters mercury should be applied for 10 to 15 minutes. We can see complete cessation of bleeding within 4 minutes. retracted well.
Application of negative pressure. A negative pressure of 650 millimeters of mercury should be created and maintained for 10 to 15 minutes, and then the machine should be put off. This procedure should be repeated every hour for 2 to 3 hours. After 3 hours, the cannula should be kept in the same position without removal and should watch for bleeding. In case of recurrence of bleeding, negative pressure should be applied by just switching on the machine. PPH always, sometimes it recurs even after cessation of bleeding in first sitting. If at all there is a recurrence of bleeding, you have to just switch on the machine and the bleeding stops. How long to keep the cannula inside the uterus? Usually the cannula can be removed after 6 to 8 hours. In case of high-risk woman, cannula can be kept inside uterus as long as the bleeding expected, even up to 24 hours. Whenever there is a recurrence of bleeding, you can just switch on the machine and the bleeding stops. The duration of application of cannula, keeping cannula inside uterus, is not rigid. It all depends on the obstetrician's decision. Suppose a cannula is applied prophylactically for a patient, the cannula can be removed even after 2 to 3 hours. SR cannula application for atonic PPH during cesarean section and in case of placenta previa.
Cannula system should be organized while setting the trolley itself. The intended cannula for application should be fixed to one side of the suction tube. Other end of the suction tube should be fixed with a thin, long cannula. This is a case of posterior placenta previa with minimal anterior extension on left side. This is the wound stitch technique which I have developed. I don't use green armature forceps. By stretching the wound four sides with fingers like this, it is possible to control bleeding, even massive bleeding. This is the another instrument which I have developed called cephalic extractor for floating head. Now placenta separated and removed. Now we apply SR cannula to prevent atonic PPH and lower segment bleeding. As this is an elective section, I am dilating the cervix with my index finger. I am using this thin long cannula as an introducer to the suction tube. Suction tube should be connected to the suction machine. Cannula inserted into the proper position. Cervical portion of the cannula should be in cervical region. Cut edges should be kept together and then back pressure applied. Then negative pressure should be applied. You can see completely contracted and retracted uterus. Blood loss less than 200 ml.
This is a new modifications I have done for the suction tube introducer. I have created an angle here. So the cannula comes out, the suction tube introducer just comes out as it is on its own. You need not insert fingers into the vagina to catch it. If you insert hand between your thighs, it will be waiting for you. You can catch it and pull it out and connect to the suction machine. Foley's catheter tourniquet technique and SR cannula for lower segment bleeding due to placenta previa at cesarean section. We can exteriorize uterus and apply a Foley's catheter as a tourniquet on the lower segment. Instantaneously, all blood supply to the uterus will stop and bleeding stops. Recently, I've seen a video by recently I saw a video by Alka Krupalani, and she used this Foley's catheter similarly
As
in his
Foley's
case.
catheter is elastic, it permits the application of SR cannula with in situ tourniquet.
Put on the machine.
This technique helps to stop bleeding in case of a central placenta previa or placenta previa. You can minimize blood loss. Now we can suture the
You can
uterus.
see complete cessation of bleeding with contracted.
You can see very
and
clearly
retracted uterus.
live how the cannula works in case of C-section. Prophylactic application of SR cannula is done for women who are at high risk for developing atomic PPH like PIH, anemia complicating pregnancy, and accidental hemorrhage, and so on.
For prophylactic application, we have to check the suction machine before the delivery itself for proper functioning. And we have to organize the cannula system. Cannula should be firmly fixed to the one end of the suction tube. Other end of the suction tube should be firmly fixed to the suction machine like this. After the delivery of the baby and before the delivery of the placenta, vagina retracted with white blade speculum. Mild traction on the umbilical cord. 5 centimeters of anterior cervix cut with the sponge holding forceps like this. After the delivery of the placenta, without wasting any time, left 2 fingers inserted deep into the cervix, cannula inserted into the uterine cavity, taking the guidance of left fingers, tip of the cannula at the level of fundus, negative pressure applied. You can see complete cessation of bleeding. Total blood loss is around 50 ml.
My advice to
Uterus
everybody,
retracted well.
my advice to all peripheral centers with suboptimal facilities like PHC, CHCs, small nursing homes, I advise them to apply cannula for every patient so that blood loss can be minimized and they won't see PPH at all, and blood transfusions can be minimized, and risk of death and risk of transport can be avoided, and maternal mortality can be brought down due to PPH. SR cannula for traumatic PPH. I suggest to apply SR cannula for every case of PPH, whether it is traumatic or atonic. In case of advanced traumatic PPH, some amount of uterine atony is always possible. Cannula corrects atonic component in uterus and reduces bleeding. When negative pressure applied, the cervical tissues get compressed firmly on cannula and stops blood flow in descending cervical vessels. If we apply gentle traction, suction tube and suction cannula, the entire uterus en masse descends down. Then we can apply speculum, visualize the tears better, and then suture the tears totally in a bloodless field. Here, we don't need to apply sponge holders to hold the cervix. SR cannula is very effective for transporting the woman action of the head. The same pump can be used to uterine cavity. It is very useful for transporting the woman to a higher center with PPH.
Manual suction pump can also be used to create negative pressure inside uterine cavity. This is useful in places where there is no power and also helps to transport the patient with in situ cannula.
Then how to remove SR cannula after the procedure? After the completion of the procedure, the cannula cannot be removed easily as the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent.
Cannula can be easily removed after gentle separation of these adhesions with finger manipulation like this.
This is the cesarean section I have done last night. And next morning, I'm removing the cannula here. You just insert the finger between the cannula and the cervix like this, and go on separating the stuck tissues into the holes of the cannula one by one. If you remove the adhesions in the cannula in the cervical portion like this, the cannula comes out easily like this. Then the question is whether SR cannula can produce inversion of uterus. SR cannula do not produce inversion of uterus, but inversion of uterus can be treated by SR cannula. What we have to do is you have to reposition the uterus inside, then apply SR cannula, then apply negative pressure, and the uterus get freezed. That atony will totally disappear, and the recurrence of inversion will not be there. And cannula is also very effective for bleeding due to coagulation failure. In the case of coevaluate uterus, we have applied SR cannula. Coevaluate uterus with coagulation failure, I have applied cannula. We could stop bleeding and we could save the uterus and her fertility function. How to clean the SR cannula? Many people were asking. There's a difficulty in cleaning. I put this video.
To clean the cannula, immerse the cannula inside water. Kink the suction tube and put on suction machine and create high negative pressure inside the suction bottle. Then release the kink. By gush of entry of water inside the cannula get cleaned.
Further, if there is any difficulty, you can call me to this number. I have given my number on the cannula itself. I will definitely respond. All of us together will try to save the mother. Advantages. This is a simple, cost-effective, life-saving and fertility-saving technique. This is a physical method. Does not depend on biological factors for its action. For the same reason, it does not fail. Suction cannula system can be organized within 2 minutes time. Bleeding stops within 2 to 3 minutes time. Cannula system works well even in case of coagulation failure. Blood loss during cesarean section and normal delivery can be brought down to 100 or 200 ml if prophylactic cannula is applied in every case. Even staff nurses can be trained and the bleeding can be stopped without any delay. Highly cost-effective, autoclavable, reusable instrument. You have to purchase the cannula only once in the lifetime. It works for your life and you can save any number of mothers. Helps to reduce maternal mortality due to atonic PPH in low resource settings. Thank you, thank you, thank you. Able to hear me? Show me.
It was a very interesting video. What I would like to say is during the past few months, we have conducted PPH webinars in South Kerala, Tamil Nadu, Karnataka, and everyone unanimously said, since the advent of SR cannula, our PPH cases have reduced drastically and our chances of doing obstetric hysterectomy, yes, that has become very, very minimal. And I would like to share another thing. Last week, I had gone to UPCOG and I was judging the poster presentation. There was a resident from Agra and she had done an entire study on SR cannula. She presented all the data. We asked her to publish it. She gave very good results with that. So it sounds really promising. It is really widely used in South. Yes, we North Indians have to be more confident and start using it. Thank you so much, sir, for such a lovely video.
Along with Preeti Kumar and Sharada Jain, we want to introduce in North India. Actually, the quality or performance of this cannula is established now. There's no question of coming back on that. But we are struggling hard to introduce in North India. If anybody can join us, no, it will be very nice for us.
We are always there. We are always there with you.
Ma'am is there with you.
You have come to Saving Mothers Conference and demonstrated.
See, I tell you one thing here. It is not the Foxy alone. The government support should be there. Without government support, you cannot enter into their.
We will like to. Yes, we will.
It should be available in every PSC, CSC.
Yes. Hospitals. That is possible only when government joins us. Otherwise, we cannot go and do anything there. You know the reason why Tamil Nadu we could succeed so well. In fact, I tell you, by next 6 months.
I think we can have
next
discussion.
See, I tell you one thing. By next December, the MMR of Tamil Nadu is going to touch around 25. So
Thank you.
so
That's
effective.
great. That is the most what we can be proud of. So wonderful presentation. Nalini is with us. There was one question in it. How to?
Ma'am has left, I think.
So okay, then we can go with the next session
Because
because
let's quickly
we
move
have
to
the panel also. Yes.
third video session. Sir's video was really mesmerizing, and it is. We all hope to use it in near future. So for video of Dr. Shashi Kabra ma'am, I would like to invite our chairpersons, Dr. Naresh Virji Bhanushali. Sir is president of Bhuj Obs and Gynae Society, director of Harsh IVF Center, and practicing since last 20 years. A very warm welcome to you, sir. And next we have Dr. Radha Mehta. She is secretary of Jamnagar Obs and Gynae Society and renowned obstetrician. A very warm welcome to you, ma'am. I would request Dr. Naresh Virji to introduce Dr. Shashi ma'am.
Good evening, madam. I am audible.
Yes, sir.
Yeah. Thank you, Sadhana madam, for giving me this opportunity. And nice to see you, my HOD, Dr. Hina madam. I am the student of Hina madam. And just I will give a brief introduction of Dr. Shashi madam. She is IMA appreciation. She got the IMA appreciation award in 2018. She is recipient of Wonder Foxy Award 2019. She is APJ Abdul Kalam appreciation award in 2020. So she is IMA WDW Karamvi award in 2021. She is Champions Award of Critical Care in 2021.
Sir, it is okay, sir.
Yeah.
Thank you so much, sir.
Over to Shashi madam for the topic on devasculation in the PPH.
Yeah. Thank you so much. Thank you so much, Dr. Sadhana ma'am, Dr. Babita Shukla ma'am, Dr. Ayushi Agarwal, Bhuj, Jamnagar, Bhanoj, Godhra Societies and Rajkot Society for giving me this opportunity. Is my screen visible?
Yes.
Yeah. So my topic is step-wise devascularization. It is a type of conservative surgical method. And this is a very beautiful picture, a copyright of Dr. B. Lynch. These are the sites for uterine artery ligation, upper and lower. And this is the site for ovarian uterine anastomosis ligation. It is not called ovarian artery ligation, as this is a misnomer. Ovarian artery is here at the level in the infundibulopelvic ligament, and we do not ligate it here. Rather, we ligate it here at the anastomosis site. So showing you one video of uterine artery ligation. Bladder is pushed down and palpating the uterine artery.
இது வேணும் இது வீடியோ கூட
Take a bite 2 centimeters from the myometrium and taking out the needle posteriorly. Then it will taken out anteriorly through the avascular area in the broad ligament. And just tight anteriorly. Remember one thing, that in the first knot there will be 2 turns. The first part of the surgical knot. Then lower ligature, 2 to 3 centimeters below the proximal ligation. Same technique. You can very well appreciate the vascular window in the broad ligament. and then it is ligated anterior. Now I'm showing you the uterine ovarian anastomosis ligation shared by my colleague, Dr. Soma. Part of mammography is taken here also. From posterior to anterior, needle taken out, seeing an avascular window in the broad ligament. And tied anterior. So coming to the most important part, the internal iliac artery ligation. If you go back to our first year classes of anatomy, then you can see here that this is the biggest vessel of our body, abdominal aorta, and it divides at the level of L4 and L5 into two big common iliac arteries. And it makes an inverted Y here in the middle. And then each common iliac artery at the level of sacroiliac joint again divides into two, external iliac and internal iliac. And there are two inverted Ys over here. So we are concerned about these inverted Ys, not this one. Here is the same picture. This is one-sided common iliac artery branching into external iliac and internal iliac. And this is the posterior branch of the internal iliac. This is the anterior branch of internal iliac. So you see that it gives the posterior branch very soon after its origin from common iliac. So how it works? Bilateral internal iliac artery results in 85% reduction in pulse pressure, 50% reduction of blood flow. This converts an arterial flow into venous flow, and it facilitates coagulation. Bleeding is reduced, life is saved. And in initial part, it is technically difficult, but there is not a very long learning curve for this. These are the two things which I require for internal iliac artery ligation. One is right angle forceps. It has got serrations and the tip is not sharp, not injurious. And this is a silk thread which I always make double. So this is the model, teaching model of internal iliac artery ligation demonstration, which I made for teaching to my students, junior specialists and residents. So first you see the anatomy here, only then one can become able to assist in live surgery. Is my sound audible? Is my sound audible in the video?
Yes, ma'am.
Sound audible. No, I mean the video sound is audible.
No, your sound is audible, ma'am.
So I'm resharing again.
Sheena, you speak, that will be better actually. Dr. Haresh Doshi, we welcome Dr. Haresh Doshi as expert. You speak, that is, I think that will be better.
Yes, ma'am, I will speak in between, but so is the sound now available? Audible?
This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery.
Yeah.
And we have to ligate the anterior division of the internal iliac artery. When we apply pressure on the external iliac artery and press it, then the femoral pulse will go. Normally in the pool of blood, this posterior division is not seen. If I place my thumb here, then the length of my folded thumb is around 3 centimeters. So I just put my thumb here at the beginning of the bifurcation, and around 3 centimeters, this is the place where I can recognize the internal iliac artery needs to be ligated. This is right angle forceps, also called mixture forceps. It is bent at 90 degrees and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. Internal iliac artery, this is internal iliac vein. They are enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the.
This is very important. Only at the place when we need to ligate.
Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this. parallel to the
big vessels.
Never do like this, because it will end up injuring the internal iliac
will prick
vein
the
and
vein.
that will be a massive bleeding. So I'm separating it like this. I've already made a place here for ligation, passing the right angle forceps from lateral to medial.
You can see why the double thread is made.
Gently I will open it.
Because in one go,
and I will get
we want
hold
to
of the
make two
glue,
ligatures.
and just gently I will come out like this.
So that we do not.
This movement is very, very gentle. Now next step is I'll cut this and make two threads.
So in one go we make two threads so as not to injure any big vessel twice.
And this is another thread. See, this is plain and this is another thread. So look at the technique of applying ligature. I've taken hold of one ligature. I'm not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand and there will be massive bleeding. So I'm giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is second turn.
Two turns in first knot.
Here.
Make the knot square and tight.
Then very gently I applied the second throw.
You have to be very gentle in doing this procedure.
And again very gently.
Never pull the artery.
Third throw. Without pulling the artery, I myself cut this. Just without giving any.
Because I know what amount of pressure I have to apply. That's why I myself do it.
I'm just getting.
So
this is common.
Now I'm sharing one case and one live video. This was a 26-year-old woman, primary with full-term pregnancy, booked initially in one facility, then ANC done at Anganwadi Center. She had labor pain on 23rd November and she was rushed to the 3rd hospital at night, went into obstructed labor, taken to another 4th private hospital and undergone emergency LSCS for second stage arrest at 8 a.m. in the morning. She had an episode of PPH at 10:15 a.m. and managed medically. Then she had another episode of PPH at 12:30 p.m. and she developed shock. And they could see that then they took the patient to OT and repaired the left lateral cervical tears and posterior vault repair also under saddle block anesthesia. By this time, patient received total 5 units of PRBCs, 4 FFPs and 2 platelets. Then at 7:15 p.m. again the patient went into shock. She was resuscitated and referred to me with 5th unit of PRBCs on flow. When we received the patient, her pulse was 146, BP was surprisingly 104/60, and because of so many bloods she received, abdomen was soft, it was contracted and no significant mass palpable, and there was significant vaginal bleeding. So immediately I took a decision because already 11 hours had passed after delivery. So I thought of opening the abdomen without wasting time. And when I opened the abdomen, there was a huge broad ligament hematoma on the posterior side from top to bottom. I performed an obstetric hysterectomy in this case, and still there were oozing at multiple sites. So, and one side uterine artery was torn. So we performed an internal iliac artery ligation. So I'm just showing you the video. This is the situation after performing hysterectomy. You can see here the round ligament ligature. This is right side. And I lifted the thin peritoneum below the round ligament on the anterior broad ligament. We basically, when we open it, then we call it opening the retroperitoneum. And Tillin says that in every routine gynecological hysterectomy, when after pushing the bladder down, we should open the retroperitoneum routinely. We should see the ureter and then we should ligate the uterine artery. And an experienced surgeon can do it in 20 to 30 seconds. So you can see here, after opening the retroperitoneum, I've separated the loose areolar tissue. You can visualize here inverted Y. It doesn't bleed much because it doesn't contain many vessels. This is the ureter in the medial flap, and there you can see the inverted Y. This is inverted Y, this is common iliac, and here is the ureter in the medial flap. Ureter is a very cooperative structure, goes on the medial side so that you can work on the lateral side. Now I'm making it more prominent, only doing dissection with my fingers. I am not taking any sharp instrument over here because this is an area where big blood vessels are lying over the psoas muscle. So this is external iliac, this is internal iliac, this is common iliac. Now I'm pressing the external iliac and trying to palpate the change in femoral artery. If we press it, then there will be a change in femoral artery. But when we press the internal iliac, there will not be any change in pulsation of femoral artery. So we have recognized the inverted Y, we have recognized the structure, and we have recognized which one is internal iliac artery and which one is external. Now I have started dissection on the internal iliac artery. So look at the dissection. It's same as I demonstrated in the model. The movement of my mixture forceps is parallel to the vessel. It is not perpendicular. See how thin covering sheath is being dissected only with the tip of the instrument, with little assistance from the assistant. And I'm separating the sheath only at the level of the proposed site of ligation, which is 3 to 4 centimeter below the origin of bifurcation of the common iliac artery. You see here. And the double thread is ready. My assistant is holding it. I'm just pulling it very gently. Purpose of putting double thread, I've already told you that we minimize the chances of injuring the arteries twice. Now it has been cut at the loop. And now we made 2 threads. And now very gently, I have to separate them. So this is what I'm doing. I keep my head calm and very gently. One has to do it here. So I've separated, and now I'm putting knots in the first ligature. There should be 2 turns in the first knot. Go and place the knot on the top of the artery. Don't pull the artery. Bow your head down. So first ligature, apply it. You still can see very nicely after pressing this gut. This is the external iliac artery. This is internal iliac artery. Now I will apply the second ligature. The distance between the 2 ligature is 0.5 to 1 centimeter. I usually apply the lower ligature first, but anyone can apply the upper ligature first also. Same method, 2 turns in the first knot. And then I apply a complete surgical knot. That means changing the, you can see here, you can appreciate there are 2 different ligatures, 0.5 to 1 centimeter apart on the internal iliac artery. See here. So while cutting it, there should not be any pull on the artery. Just gently hold the 2 threads and nicely cut it. So now you can see internal iliac artery ligated here, and the ureter is on this side in the medial flap. This is internal iliac artery. So this is basically the technique that the right angle forces must be entered from lateral to medial side, never from medial to lateral side. If we enter from medial to lateral side, then there are chances of pricking the external iliac vein. So this is a very important safeguard, right angle clamp to be inserted from lateral to medial side on both the sides, right and left. So the tips for internal iliac artery ligation, these tips I have made by my own experience. Open the retroperitoneum from round ligament to infundibulopelvic ligament. Up to the lateral pelvic wall, at least you can cut 5 to 7 centimeter retroperitoneum. And this is for anterior approach, and for posterior approach, you make a nick 2 centimeter below and 2 centimeter lateral to the sacral promontory and lift that peritoneum and cut it. And once you have cut the retroperitoneum, do only finger dissection. You can practice it in gynecological cases, in routine gynecological hysterectomy. And please, after pushing the bladder, please don't ligate the uterine artery as such. You open the retroperitoneum, see the ureter, then you ligate the uterine artery. Then third thing is you look at the bifurcation after opening the retroperitoneum, and bifurcation is recognized by inverted Y. And in the inverted Y, you recognize internal iliac artery as a medial structure which does not cause any change in femoral pulse. External iliac artery does cause a change in femoral pulse because femoral artery is a continuation of external iliac artery. Then movement of mixture forceps is always from lateral to medial. Just remember the word lateral to medial, lateral to medial, and lateral to medial. And careful not tying in the cavity, as I've shown you. Two ligatures should be 0.5 to 1 centimeter apart. And remember one thing, always do bilateral, because the literature says that the chances of free laparotomy and morbidity increases, even mortality, if we do unilateral half-hearted internal iliac artery ligation. So thank you so much.
Thank you so much, ma'am. We would like inputs of our chairpersons. Dr. Radha Meeta and Dr. Naresh Virji.
Yeah, excellent narration, Sasi Madam. Excellent video presentation. Just Madam, only one question.
Yes, sir.
That when there is a central placenta previa or bleeding from the lower segment,
yes,
so
sir.
how much useful interiliac, or what we do in such cases when it doesn't stop bleeding after interiliac ligation?
Sir, if we have done hysterectomy and we have performed internal iliac artery ligation also, and still the bleeding is there, then one thing is supportive management by FFP, blood, PRBCs, etc. And you can pack the abdomen in 3 cases after doing this. One case was with jaundice. So I packed the abdomen with complete drape sheet.
Okay.
And patient became stable. And after 48 hours, we reopened the abdomen to remove that sheet. So this is one method of arresting blood loss and achieving hemostasis. Packing is very good. And usually in a central placenta previa, when we ligate the internal iliac artery, then the bleeding stops, because after all, uterine artery is the main branch of internal iliac artery which supplies the uterus. But one thing, the better utilization of internal iliac artery is in placenta accreta spectrum disorder. And in these cases, when we are doing the cesarean, then after cesarean, first it's better that we do bilateral internal iliac artery ligation, and then we should go for obstetric hysterectomy with placenta in situ with no attempt to separate the placenta. Because if we go for hysterectomy first, then there will be massive bleeding throughout when we are doing obstetric hysterectomy. So in a placenta accreta spectrum, first do internal iliac artery ligation.
If we do uterine artery embolization in placenta accreta spectrum, still we have internal ligation?
Ma'am, uterine artery ligation, if the facility is available, you can always do it. In my hospital, this facility is not available. And in most of the hospitals in India, this facility is not available. So it is my sincere advice that all the obstetricians who are involved in delivery and cesarean should learn this art. At least patient can be saved in when the facilities are less.
Yes, actually, I would like to respond to Dr. Babita, this thing, arterial embolization. Actually, no professional body recommends the use. It has not approved efficacy of uterine artery embolization in placenta accreta spectrum. Own issue of thrombosis, necrosis, and the vessel.
There are complications.
And beside, it is availability issue. But in Delhi, if it is not available, like what to say of them? So many things that is places where the things are not available. So I just want to emphasize that actually the arterial embolization is not considered so good, and always in a hemodynamically unstable patient, it is always considered in a relatively stable. So particularly for placenta accreta, no professional body has actually approved this, proven efficacy about it. So it is just for I
have a series of cases of internal iliac artery ligation published in one of the international journals, and this is very useful in many situations of postpartum hemorrhage, even after hysterectomy or before hysterectomy. It can be utilized both ways according to circumstances.
Ma'am, we had a team from Lucknow. Those people are doing uterine artery embolization. So they were saying that they're getting very promising results with it.
Yeah, I have no
experience. Actually, overall, what is the issue with placenta accreta? There is a lot of issue with the focal accreta, histopathological diagnosis. So it is an overall scenario where we say always the individual people, always the radiologists say that it is good. But what I'm which is just now I delivered keynote address, and that is the updated recommendation that obstetrical hysterectomy is the key thing. And we have to we very particular about defining and diagnosis of various like a spectrum of placenta accreta syndrome. So this is, and I think my chair, yes, Dr. Harish Doshi, welcome, Dr. Harish Doshi's comment.
Thank you, madam. Just as you mentioned, it is for a relatively stable patient and not a severe PPH or in an acute severe condition. In a moderately PPH, we have done this and it is not that bad, but facility is there in our adjoining institute. So we have to shift the patient to adjoining institute. We did in many cases of fibroid and other dissertations also. But for PPH, you rightly mentioned that you have your relatively stable patient. A severe bleeding, PPH, then interiliac ligation, hysterectomy is the best answer.
Thank you very much for it. Babita, I think we should proceed for panel discussion.
Yes,
Shiba and Dr. Josna, our panelists are waiting.
Our panelists and our moderators are eagerly waiting. So let me introduce, we have two very expert moderators with us, Dr. Josna Suri ma'am. She is Professor BMMC, kindly display CV, Vardhaman Mahabir Medical College, Safdarjung Hospital. We have listened to her earlier also. She's really, really good at her job. And along with her, we have co-moderator, Dr. Siva Marwa. She has got a very impressive CV. She is again in the Department of Obs and Gynae, BMMC, Safdarjung, New Delhi. She is associated with Critical Care Obstetrics team, DQM Training Division, Quality Cells team, Member Labor Room Quality Care team of Lakshya, course faculty for Critical Care course in OBS. She is faculty and she is holding many important positions, recipient of several awards, the APJ Kalam Champion Obstetrics Critical Care course by Delhi Gynae Forum, and she has Outstanding Contribution Award by ISCCP in 2018 and 21, and the Women's Day Theme Award. A very warm welcome to our co-moderators. We have Dr. Harish Doshi as an expert panelist. Sir is Professor and Head of the Department of Obs and Gynae, Gujarat Cancer Society Medical College and Hospital in Ahmedabad. He has written 3 books, 3 booklets, and 21 book chapters, published 31 scientific papers in national and international journal. Sir is member of editorial board with 3 journals, peer reviewer of 4 journals. He has been faculty more than 200 times in national and international level conferences. Sir has been Vice President Foxy West Zone in 2019, Governing Council member, ICOG 2001-22. A very warm welcome to you, sir. We have an expert of panelists, Dr. Jigna Ganatra from Rajkot. She has worked since last 15 years as an obstetrician and worked as a consultant obstetrician and gynecologist at other reputed institute of Rajkot also. Then we have Dr. Prakash Farmer from Rajkot. Sir is endoscopic surgeon and high-risk pregnancy expert. Foxy recognized training in endoscopy, panel surgeon in government laparoscopic tubal ligation program. A very warm welcome. We have Dr. Puneet Khatri. Sir is diploma in advanced gynae endoscopy, CICE France, an IVF specialist, practicing in Kutch in 22 years. And he has presentations in many state conference, national and international conferences. Then we have Dr. Hina Patel from Jamnagar. Ma'am is Professor and Head of Obs and Gynae, retired in MP Shah Government Medical College, Jamnagar, and presently Professor of Obs and Gynae, Shantaba Medical College, Amreli. And then finally we have Dr. Divya Tekani from Bhuj. She is Diploma in Reproductive Medicine, Senior Consultant in Fertility, and Professor Adani Medical College. So very warm welcome to all our moderators, our experts and our panelists, and we'll look forward to a very, very, very interesting panel.
Yeah, good evening. So Dr. Shiba will begin with the, okay. So I think introductions have been done, Shiba. So Shiba, unmute yourself.
Yes, ma'am.
Yeah, so you can show the full screen.
Yes, ma'am. Is it visible, ma'am?
Yes, yes, it is visible. Yeah. So Yeah, so we can go, we can skip all this. It has been done already. Yeah. So at the outset, I would like to thank Dr. Sadhna for, this initiative which he is taking to save the life of the women. And her passion for women's health is something which is, very familiar and known to all of us. And we really wish her all the best for the upcoming elections and wish to see her as the leader of all other obstetricians, and we want all her goals to be fulfilled. So to start the panel, I have been following the sessions from the beginning, and it has been a wonderful, I think, panel, the sessions in which so much has been discussed. So this panel is going to, we will be discussing 3 cases with little bit unusual cases, which Dr. Sadhna wanted us to, not the routine cases, but something which is out of the ordinary. So to give the background, we have got a obstetric critical care unit in our hospital, in Safdarjung Hospital. It is one of the first HDU and ICU which the obstetricians, we are running it on our own. And it was started in 2016. So we have a huge influx of high-risk cases. And Shiba, you can show the next slide. Yeah, so these were, one of the papers in which we published. We had seen that hemorrhage was one of the leading causes of admissions in our critical care unit. Of course, if you see the contribution of PPH, it was 6.4% only. So because it is a teaching hospital, and obviously with all the things which we are doing these days, active management of 3rd stage, and with all the protocols in place, we don't expect that the book patients will have PPH, which will end up in the critical care unit. But all these patients who came were all referred cases. But we have now got zero tolerance for PPH, which is, leading to critical care admission. So I think these webinars are very important for this kind of, orientation for all our colleagues, so that, because if we still see the data in India, we can see that 35% of the mortalities are being contributed by hemorrhage, and amongst this, 2/3 is the PPH. So we go forward. Shiva, you can go forward. Yeah. So the PPH definition, we all know it is a very conventional definition, which we all learn from the medical school, that 500 ml after vaginal delivery and 1000 ml after cesarean section. But there are a lot of fallacies in this definition. And now, the ACOG very clearly says that don't go just by the volume. So we have to see any symptoms or signs which are causing, hemodynamic instability should be regarded. And of course, or they say more than 1000 ml regardless of the route of delivery. So we have to realize that almost a woman can lose 2.4 liter of blood without having any symptoms. So it is the very, very important, as Dr. Sadhna had said, the golden first hour. Shiba, if you show the next slide. Yeah. So here, if you see, the possibility, this is one of the, published paper in which we are showing you can see the graph that the probability of survival, it goes down as the time is passing. And with the 60-minute crossing, the probability of survival goes to about 15 to 20%. So if you are not going to take action in the major PPH during the golden hour of resuscitation, we are, very likely to lose the patient. 750 ml of blood flow per minute is what the uterus receives. So you can imagine what kind of tap opens. I think with this introduction, I hand over to Shiba. Dr. Shiba will discuss the 3 cases with our panelists, and then, we'll go forward with the discussion. Thank you so much. Shiba, you can continue.
Thank you, ma'am. So beginning with the first case, it is a 22-year-old primary gravida at 35 weeks period of gestation came to Safdarjung emergency with complaints of yellow discoloration of eyes and urine since 3 to 4 days, vomiting since 3 days, and labor pain since 4 hours. On examination, her pulse was 92 per minute, blood pressure was 130 by 90 millimeters of mercury, respiratory rate was 26 per minute, she was afebrile, she was maintaining a saturation of 96% on room air. On per abdominal examination, the uterus was term size, irritable, she had cephalic presentation, and fetal heart rate was 120 beats per minute but was regular. On per vaginal examination, os was 3 centimeter dilated, 50% effaced, patient was at -2 and membranes were present. So she was admitted and all her investigations were sent. Her hemoglobin came out to be 8.4 gram per deciliter. Her TLC was 17,700 millimeters per mercury. Her platelets were normal. LFT, the total bilirubin was 12.6 milligram per deciliter, and the AST, ALT were also high with a tune of 544 and 344. Her random blood sugar was 67, and in KFTs, the creatinine was 1.7 milligram per deciliter. She had deranged coagulation profile with PT being 52 seconds and INR being 2.7. Though all her viral markers were negative, an ultrasound done showed a single live fetus corresponding to 34 plus 2 weeks period of gestation. Liquor was adequate, but placenta was upper posterior. There was mild ascites and bright liver with right pleural effusion. So my first question goes to Dr. Jigna Ganatra. Ma'am, what is the provisional diagnosis and what are your concerns for this patient?
Yes, first of all, I thank Dr. Sadhana Madam and all the team for inviting me. And it is such a wonderful discussion. Since evening, we are learning a lot from all the teachers and all the stalwarts. So regarding this patient, considering her history, clinical examination, and investigation reports, my first provisional diagnosis goes towards acute fatty liver of pregnancy. And second, uncommon types of viral hepatitis such as hepatitis E or herpes simplex hepatitis with pregnancy. And my concern regarding this patient, first of all, this patient should definitely be managed in the tertiary care center, where the facilities for ICU and other gastroenterologists, intensivist, nephrologists are available. That is 100% confirmed. And another thing is that this patient, whenever this patient comes, I would like to take large bore IV cannula. I would like to further advise investigation like serum uric acid. I would also like to get done arterial ammonia to rule out hepatic encephalopathy. And rare cases of, we have done this viral markers for hepatitis B, A, and C, but HEV is remaining. So I would like to rule out hepatitis E also. That is also not very uncommon in pregnant patient, may happen with this situation. And also HSV IgM, that is herpes simplex virus, IgM also I would like to do. And also electrolytes also not done. So I would advise electrolytes also. As patient is already in labor and having vomiting, would like to give her antiemetics, IV fluids depending on the reports, and will take large bore cannula, and her INR is also altered. So we'll keep ready red cell concentrate and fresh frozen plasma. Her sugar is also very low at present, 67, which is
Thank you, Dr. Jigna. I think,
yes, ma'am. Hello.
Yes, ma'am.
yeah, there is some
Actually,
disturbance.
yeah.
There is some disturbance, I think, from.
Yes, ma'am.
Okay, so I will give her dextrose 25% also, and considering this, I will after evaluating all A, B, C, D, which we do for all the patients, will further allow for progress of labor with definite monitoring, and will keep vigilant for PPH, and also pediatrician also I will keep in contact, that whenever labor progresses, emergency neonatologist will also be required.
Yes, ma'am, you very rightly said. So the diagnosis first differential was acute fatty liver of pregnancy, but our main concerns was that being AFLP, this patient had an increased risk of PPH. She's already anemic, she's going into active labor, and she has deranged coagulation profile. And apart from this, we were anticipating complications which are related to acute fatty liver of pregnancy, as you very rightly said, like hypoglycemia, DIC, hepatic failure, hepatic encephalopathy, pulmonary edema, sepsis, and multi-organ dysfunction syndrome. So this patient, the labor progressed spontaneously and she delivered a term live male child of 2.5 kg by normal vaginal delivery with right mediolateral episiotomy. Active management of third stage of labor was done, but still patient had atonic PPH with a blood loss of around 800 cc as we had anticipated. So my next question goes to Dr. Prakash Parmar. Sir, what should be the immediate management and what is the bundle approach of PPH and how does it help?
Thank you. Thank you for inviting me. First of all, I think it's an honor for me to be in the panel when Hina Madam, who is a professor and HOD when I was in MBBS, and we have always read a book of Haresh Doshi sir, and I'm in the panelist with these two stalwart faculty. So in this case, now once the labor has been done and patient is having a PPH, so always first of all there is the call for the help. Whatever staff you have, your expert staff, anesthetists, other gynec, if you are not comfortable in management of any emergencies, always call for the help. Secure 2 cannulas, IV fluids, and uterotonic medicines to control the PPH. Okay. For the bundle approach in PPH, there is two things. First is the primary response. As we have learned in the lecture that the primary response is the uterotonic drugs, crystalloids, uterine massage, and tranexamic acid 1 gram. And once it is a refractory PPH, one can give either compression, bimanual compression, or aortic compression, balloon tamponade, and non-pneumatic device.
Yes, thank you so much, sir. So FIGO 2022 recommends incorporation of the PPH bundle approach and really emphasizes that they should be in place in every maternity hospital, whatever setting it would be, like a primary, tertiary care, a primary, secondary, or a tertiary care center. And we also would like to highlight this spin girl, which was given by the USAIDs, that it shows that how to demonstrates that how the PPH should be managed. So at the head end, the person who is there, she should check the airway breathing, administer oxygen, give sublingual mesoprost, keep the patient flat, note times of relevant events, and reassure women. The person who is at the arm's end should keep on checking the vitals, gain IV access with whiteboard needle, as sir rightly pointed out, send samples for CBC clotting, cross-matching, as ma'am said, start fluid resuscitation, give drugs, and if we need transfer, we can go consider aortic compression as well. And the person who is sitting at the perineum, she should call for help, she should massage the uterus, coordinate with helpers at head and arms, and to catheterize the bladder. If atonic PPH is there, she should apply bimanual compression, consider Foley's tamponade, and review the causes of PPH, which are the 4 T's. So this is for the postgraduates who are attending this webinar. So the uterine tone was reassessed in our case. It was well contracted, but there was a mild trickle. Estimated blood loss was around 1000 ml. Vitals remained stable throughout, and urine output was maintained. So my next question to Dr. Puneet Khatri, sir. Sir, what would you like to do now, and what is the role of balloon tamponade?
Hello, am I visible or no?
Sir, you are audible but not visible.
Yes, but when I start the video, though I see the dialogue, you cannot start your video because the host has stopped it.
Okay.
Sir,
I think
you can move from the
it's okay, no problem. Thank you very much. Thank you very much, all the
You
faculties.
can carry
Thank
on
you,
with
Sadhana ma'am.
the answer.
Sadhana, yeah. So whenever we anticipate, or whenever we recognize that uterine atonicity is going to develop, whenever we anticipate or whenever we recognize that atonic PPH occurred, our action should be very fast. And we must increase the dose of oxytocic agents. We can increase the dose of oxytocin. We can give prostaglandins. We can give carbetocin also nowadays. And after all these measures, we can think of mechanical compression, either by the balloon tamponade, many types of balloon available in the market, or we can use just Samartha sir has mentioned, we can use a suction cannula also. Bakri's balloon, Cooper's balloon, and Chhattisgarh balloon, many types of balloon, modified balloon, condom balloon available. So we can use this type of balloon tamponade, but I think the suction cannula, SR suction cannula is much more effective and cost effective in all types of setups. So
Yes, thank you, sir. So when all the medical management has failed, so the first step to surgical management is the balloon tamponade, which exerts a mechanical effect.
Yeah.
And it is very important for all the postgraduate and the budding obstetricians to learn how to put it and how to master this art, because it can really save lives. And there are certain contraindications to balloon tamponade, like purulent infection in a patient, or if she has an untreated uterine anomaly, or if she's really in DIC, then it might be not considered. And post balloon tamponade, don't forget to catheterize the bladder and mark the abdominal wall at the level of fundus, because if it's rising above the mark, then we should suspect failure of the device which you've inserted, and that means that it is ongoing bleeding and patient needs urgent exploration. Word about when to remove the balloon tamponade. There is no fixed guidelines, and it is based upon actual how much blood loss has occurred. Usually 4 to 6 hours is what WHO advocates, and we should deflate at the rate of 20 ml per hour to half the volume at 12 hours, and it's commonly kept in situ for 24 hours with a check for infection. So despite of uterine tamponade, this patient continued to trickle. So now I would like to ask Dr. Hina Patel ma'am what to do next, and how should we manage her coagulopathy? Dr. Hina Patel, ma'am.
I think she's she's not there.
She is there. Dr. Haresh Doshi. Dr. Haresh Doshi is our expert.
Dr. Haresh. Dr. Haresh. Yes. Dr. Haresh, we request you to take this one.
Before I answer this question, I just want to add to that previous discussion that Dr. Puneet has rightly mentioned carbetocin as the first bundle response, first as a bundle approach, right? The uterotonics nowadays, as on now, carbetocin is recommended as one of the component by WHO for AMTSL, that is a prevention and not the therapy. But we have used in our setup now carbetocin for the treatment also, particularly cesarean section. So that for atonic PPH, that is very important. And second thing, for balloon tamponade or section, I just want to convey, as in the previous session also, madam told that pressure after hysterectomy and intervenous ligation in step by this devascularization. She mentioned that pressure was, the seat was kept for 2 days. Remember, pressure is the most important method of hemostasis. Apart from surgical, that is the ligation and hysterectomy. That pressure may be from outside, that was for B Lynch and all that. You compress from outside, bimanual massage, or pressure from inside, that is balloon tamponade of any method, or negative pressure from inside, that is SR cannula. So pressure works everywhere. Positive pressure from outside, positive pressure from inside, or negative pressure from inside. Now, this whatever SR cannula is there, now a company has come in USA with JADA system. That is the same method, but it is very commercially available. It is not that cheap. And also like balloon, that is an ESM balloon. Every second matters. That is ESM, it is called Dr. Burkes. It is FDA approved, US FDA approved. You can purchase and keep it in your labor room for that purpose. That is a balloon. Otherwise, you can make Chhattisgarh balloon, as Dr. Nalini Mishra is very simple to make. But otherwise, ready-made balloons are available, ESM balloon technique. So what I want to convey is the pressure is the most important hemostasis. The new thing has come, mini sponge devices. The mini sponge is a small sponge are introduced. They will absorb the blood, inflate 10 times and fill up the uterus with the sponges. So that is again a pressure, again like a balloon, some pressure. So this pressure I wanted to highlight. Now, manage the coagulation, you have no option, you have to give, right, the clotting factors which were deranged because of liver disease. So FFP is to be given to this patient, and also the fibrinogen. But fresh blood, nowadays we don't have, we give all the pixel volume, but in the ratio may be different in a surgical side or in an obstetric side, but better I would recommend 1:1:2 in the ratio of blood, FFP and platelets. We must transfuse to this patient so that coagulation disorder which is there will be corrected and clotting will happen and bleeding will stop. Madam Hina is speaking in between. I don't know.
Dr. Hina, are you there? Dr. Hina?
It's okay. It's okay.
Dr. Hina, yeah, she has joined, I think.
Yes,
Dr.
yes.
Hina, yeah, so we were talking about that how to manage the DIC in this patient. Would you want to give some inputs? You're muted. Dr. Hina, you are muted.
Ma'am, please unmute yourself.
Ma'am, please unmute yourself.
No, madam, you are muted. I think she's not able to unmute. There is some problem at her end.
Ma'am, I think she's joined from the speaker's link. From the
No,
delegates
no,
link.
I can see her. I can see her.
Ma'am, just click once only on unmute. You
Her
are
video is
clicking
on.
2 times. You are
Yeah.
clicking 2 times. Just click
Her
once only
video
on
is on.
unmute. Yes,
Please.
now it's
Yes,
unmuted.
now we can hear.
Now you can hear?
Yes, we
Yes,
can.
yes,
hear.
ma'am.
Yeah.
Okay. In this case, you have not mentioned one thing, that is fibrinogen level, because fibrinogen levels are low when acute fatty liver of pregnancy is there. And in these, whenever this coagulopathy is there, mainly fibrinogen levels we have to bring down and bring up to at least 150 mg%. And so fibrinogen and FFP should be given and followed by cryoprecipitate. That is the indication in these cases. 2 cryoprecipitate pools should be given, that is 10 to 20 ml per unit. And we have to bring up the fibrinogen level to at least 200 mg%. Fibrinogen concentrate, but cryoprecipitate is better than the fibrinogen concentrate. And every 3 to 4 PCV, we have to give continue FFP also, alternate. And platelet, of course, it is 1.5 lakhs, I think, in this case.
Yes,
But we have to see for platelet also at the same time. So if we manage these things better, then probably the trickle would come down, I mean, stop, and patient would be better gradually.
Yes, very rightly said, ma'am. So all the blood products components, they should be given, and we should aim to have an hemoglobin above 7, platelet count more than 50, fibrinogen more than 300, and PT APTT of less than 1.5 times the normal values. So fibrinogen, as you said, it is a very good thing because fewer thromboembolic events have been reported. It can be stored at 4 to 8 degrees. But if we give normal FFPs and cryoprecipitates to correct hypofibrogenemia, which we usually do to increase fibrinogen concentration by 1 gram per liter in a 70 kg adult, approximately 1000 ml of FFPs or 260 ml of cryoprecipitate would be required, which is a whopping ask. So, but the cost is a limiting factor for fibrinogen and it is not available easily. Though we had experience under Josna ma'am in our HDU treating this patient with fibrinogen, and it really worked wonder. And there's also like people talk about recombinant factor 7A, but it should be always considered only once all the other factors, all the other treatment options have been exhausted, because the bleeding sensation though occurs in 10 to 40 minutes, but the concern is the thrombotic complication which is associated with this. So what are the precautions during delivery or cesarean section in such patients? Can I ask Dr. Divya to take this question? Dr. Divya Tikani, ma'am, are you there?
Otherwise, Shiba, our expert, can take the question. Yes. I think. Yeah.
So I would request Dr. Doshi sir to please take this question. So delivery, if this patient goes for labor, because she was in active labor, she has to be delivered, or she undergoes cesarean. So what precautions every obstetrician should be told about to take?
So naturally, with all cesareans, when there's the coagulation disorders, we should be very accurate in in our performance, dissection of all layers in cesarean section, not cutting the uterine wall with scissors, finger slitting, delivery of the So that because of coagulation disorders, there will be bleeding from every layers, and we should be adequate in controlling the hemorrhage by surgical technique also. Then at the time of surgery also you should give coagulation, risk factor blood products as well as tranexamic acid, which is used nowadays. we should always give that. That helps in building. And as you mentioned, you are using fibrinogen. It is very costly, but it is doing wonder. But we have used platelets. In this case, platelets are not that less, 1.5. But still, whenever that is a coagulation disorder, along with FFP and PCV, we always transfer platelet, maybe 112 or 114. That is one thing. And if there is a oozing, then you keep the drain before you close the whole abdomen and do the dressing, so that hematoma will not occur post-operatively.
Yes, sir. So very nice, sir. And we must also keep a vigilant eye for infection. So I think Dr. Puneet has raised his, Dr. Prakash sir has raised his hand. Sir, if you would like to add something.
I want to add only thing that this is the pure case in which there is a definite role of intensivist also. So
yes,
most definite role of intensivist also. This is I think jaundice with pregnancy is a much difficult case even with the placenta previa. Okay, so definite role of intensivist, and you cannot predict the DIC. So there is definite role of ICU, and so such kind of cesarean section or delivery should be conducted only in the multidisciplinary approach or either in the institute. Okay.
Very correctly said, sir. Sir, Dr. Puneet, you want to say something, sir?
Yes, hello. I would like to add one more thing. In this type of patients with coagulation disorder, particularly hepatic factor, we need to add vitamin K straight away. Vitamin K also. And I want to add two more points, that while preparing for all these types of measures to manage atonicity, we must apply, the assistant should continuously apply pressure over the sacral promontory to make the aorta partially compressed.
Yes.
So it will reduce the blood flow towards the pelvis and uterus, and we can increase the dose of oxytocin. We can 16 ampoules in 1 pint of the liquid Ringer solution. So total 80 units of oxytocin, 16 ampoules in 1 pint. It makes uterus. It's very much effective. I have used personally. So.
Yes, sir. Aortic compression really helps, as Haresh Doshi sir already said that compression is most important for controlling PPH, whether it's external or it's internal. And it also helps, especially if you think of transferring the patient from a primary center to a tertiary level center. So it helps us. And also there is role of the pneumatic anti-shock garments as well while transferring such patients who are suffering from massive PPH. So now quickly going on
about the oxytocin, though I would beg to differ that 80 units would be very high, and there is a risk of hyponatremia with when we give these high doses along with the fluid, and
but
these
that,
patients
I agree with you definitely, but hyponatremia can be treated later on, but atonicity
no, sir,
patient
Dr. Puneet, I would like to just add that in acute liver failure, hyponatremia can worsen the brain edema. So these are one case in acute liver failure. We have to keep the sodium levels towards the higher side. So we can't, the patient can't tolerate hyponatremia. The brain edema can worsen. So we have to be careful. So I think we should be careful about the doses of oxytocin.
And also, once the all oxytocin receptors are saturated, further oxytocin will not
help. Yes, sir. Very rightly said. Okay, Shiva, we can go on with the next case now.
Yes, ma'am. So the second case is she was a para 1 live 1 with previous vaginal delivery, which happened 12 hours back and referred to Safdarjung Hospital with history of traumatic PPH. She had cervical and vaginal lacerations as per the referral sheet with PAC in situ. On examination, her heart rate was 120 per minute, blood pressure was 90 by 65 millimeters of mercury, her respiratory rate was 28 per minute. She had a saturation of 97% on room air and pallor was present. She was clinically 6 grams. On per abdomen examination, uterus was around 20 week size, well contracted, and on local examination, her PAC was partially soaked. So I would request Dr. Jigna ma'am to outline broadly the steps of management in such patient when you come across in emergency. Dr. Jigna Ganatra ma'am.
Yes, ma'am. Considering her history and clinical examination, as she has tachycardia, BP is also 90 by 60, and she is also having pallor. So she may have lost blood and she is having PPH. and uterus is contracted. So immediately, preferably, I would like to shift this patient first to intensive care unit. ICU shift we will do. Definitely take IV line, large bore cannula, and we'll do take samples for the report. We have previously told that we will take 2 lines, first for resuscitation, and crystalloids we will start her crystalloids, and from the next line we will take samples for liver function test, renal function test, and for managing coagulation profile report, and for managing red cell concentrate, FFP, and cryo if required, depending on the reports. While awaiting for reports, I will also get done her ECG, and if preferably if available, echo also can be done to see IVC, whether fluid, depending on that fluid requirement, we can start. We can give tranexamic acid to this patient, and a supportive treatment like antibiotics and all. After complete resuscitation, only I will think for removing the vaginal pack. And that also, I will not remove this. I will shift this patient after resuscitation to OT. I will tell the anesthetist to remain there. And under anesthesia, preferably if she is fit, I will get it done under anesthesia. And I will thoroughly check the cervix, vagina, and do the complete exploration of the cervix and vagina, and will suture the cervix and vaginal tear if required. And if recurrent hematoma, recurrent thing is there, then I will think for embolization or to search for the arterial, any definitely cervical or vaginal artery leak, definitely.
Yes, ma'am, very well highlighted. You have highlighted the fact for our all postgraduates that it is very important for us to not take out the pack whenever we see a patient with pack in situ being referred to us in emergency. We must resuscitate the patient, make arrangements for the adequate blood and blood products, take consent for laparotomy and exploration, and always remove the pack under anesthesia, explore and proceed accordingly. So that's a message we want to give. So cervical exploration was done in our case, and a cervical tear of 6 to 7 centimeter was noted at 6 o'clock position, and a right lateral vaginal tear was seen. In the apex could not be reached. So Dr. Prakash sir, how should we manage the situation now?
As Dr. Jignam has told that after resuscitation only the pack should be removed. On exploration, we have found cervical and vaginal tear, and you have mentioned that the apex we are not able to found. Many a times we can do that we can take a one stitch and that give a traction, then we can find the apex. But if the apex is very high, or we are suspecting the broad ligament hematoma might be there, then we have to convert it into a laparotomy, and we have to find out from where it is the bleeding is there from the broad ligament, and we have to do the suturing accordingly. Okay, we have to ligate the vessels either interiliac according to the size of the hematoma and according to the bleeding.
Yes, correctly said, sir. So cervicovaginal exploration has to be done with the traditional 3-sponge holder technique, and vagina should also be completely explored. And the pitfalls of repair of vaginal tear is that sutures should not be placed flat to the fornix. This is the tip which we want to give to everyone. It can result in ureteral ligation inadvertently at times. And if the tear is not, like in this case, if the apex is not visualized, so we must proceed for even abdominal exploration. And we must not drain stable vaginal hematomas if the patient is stable, because that leads to even more blood loss. Arterial or heavy active vaginal bleeding should not be treated with packing, as this has the potential to divert blood into the retroperitoneum. A vaginal balloon or packing can also be useful at times to tamponade venous oozing before or after repair of vaginal laceration. So these are the some tips. And when a word about colporexis, when primary only vaginal vault is involved, and secondary when the vaginal wall tear along with cervical tear is seen, which is complete colporexis, and such has to be managed. If it is small and incomplete colporexis, repair is done under GA in OT using 10 Vicryl, and for complete colporexy, laparotomy has to be done and definitive surgery, which may include hysterectomy after resuscitating the patient. So my next question, Dr. Puneet sir, laparotomy was done.
Madam, can I interrupt? Yes. But cervical exploration, you nicely mentioned that 3-stop technique. But nowadays, I recommend to my students that you just push the fundus, postpartum uterus, fundus of the uterus at umbilical, from umbilicus, abdominal side. The cervix will come so down, it will be at the introiters. It will be at your doorstep, you can say. And then you can nicely suture. So rather than struggling with speculum and all that, 3-stop holders and all that. So you just push, because postpartum uterus is very mobile. So you push the fundus and cervix comes at the introiters. So you can see any laceration, tear of apex of the cervical. So without 3-stop holders also, you can adequately deal with that cervical tear. Okay.
And always look for posterior to posterior lip of cervix. Many a times after instrumental delivery, people are not able to find out from where it is bleeding, but posterior to posterior lip of cervix, most of the time it is missed.
But when you push the fundus, everything will come down. Point will come down. Very nice.
Yes, sir, yes.
Everything will be visible, sir.
Yes,
Thank you, sir. Very good tip, sir. Going ahead, laparotomy was done in this patient and a big broad ligament hematoma of around 6 to 7 centimeter was seen on the right side. So, Puneet Khatri, sir, how should we tackle this patient now and what are the challenges and alternatives in the management?
So on the laparotomy, if we see the hematoma, we need to drain the hematoma, secure the hemostasis, and whenever there is the bleeding is under control, there is no need for further management after draining the hematoma. And when whatever the devascularization we should perform it out, and we must investigate also for the coagulopathy, secondary consumptive coagulopathy because of the hematoma.
Yes, sir. So this was the picture of the patient, and as already mentioned by Shashilata ma'am in her video, that we must proceed to for internal artery ligation, which should be in the armamentarium of all the obstetricians and as quickly as possible. And the procedure has already been explained, and the complications and what are the do's and don'ts, and how is it different from the embolization. So before we go on to the third case, I would request Dr. Haresh sir to please give some expert comments.
In broad ligament hematoma, it is if a venous origin, it will slowly expand. If it is an arterial origin, it will suddenly decrease the blood pressure. And bright red hematoma, and with a fast incline. In that, you open the leaf of the broad ligament. Mostly, the hematoma pushes the ureter laterally. Normally, in internal ligation, we keep the ureter on the medial side, and then we do that. So that only thing you have to remember. Otherwise, with saline flushing, you can remove the clots. It is the tissues are staying, may be difficult to identify, but still you can make out the ureter, avoid and go for internal ligation.
Yes, very rightly said, sir. Thank you, sir. So proceeding to our last case.
One thing to add, if hematoma is not increasing in size, do not disturb it.
Yes, ma'am.
Just ligate, try to ligate the vessels only if they are visible. Otherwise, leave it. Otherwise, when you go for exploration, it will increase the amount of blood loss.
Correct, ma'am. So quickly going to the third case, which is the last case. Mrs. X, 25-year-old, unbooked para 1 live 1 A3, was admitted through gynae emergency in Safdarjung Hospital on postnatal day 8 of preterm vaginal delivery. With the complaints of pain abdomen since 2 days, bleeding per vaginum since 2 days, she soaked 4 to 5 pads which were fully associated with passage of clots. She had history of 3 spontaneous abortions in her first trimester, each followed by dilatation and curettage, when her obstetric history was explored. Her last delivery was preterm at 32 weeks, where she delivered a 1.6 kg baby, and baby was admitted in nursery. On examination in emergency, her general condition was fair. She was afebrile, vitally stable. Pallor was present. She was clinically 7 gram%. Per abdomen, there was no evidence of any organ enlargement. Uterus was 16-week size, well contracted. On per speculum examination, mild bleeding was present with no clots. Per vaginal examination, the os was parous. Uterus was 16-week size, anteverted, mobile. Bilateral fornices were free and non-tender. So this was the scan which was done. Patient was admitted and for observation in ward. Routine investigations were sent, came within normal limits except her HB, which corroborated to 7.2 as we clinically expected. Ultrasound pelvis was suggestive of postpartum uterus with a heterogeneous collection of 6 into 3.5 centimeter on the posterior wall with increased vascularity. The bilateral ovaries were normal and no free fluid on the pouch of Douglas was seen. So my question for Hina ma'am, ma'am, what is the differential diagnosis for this case? How would you proceed to manage the case? Should we proceed for DNE directly? And what are the risks if we do that?
Differential diagnosis would be retained products of conception, a placental bit, or a AV malformation, or rarely, very, very rare choriocarcinoma, and sometimes usually placental polyp. But AV malformation, looking to the sonographic picture, it goes in favor of that. And rarely choriocarcinoma also would be there. And second question is, if facilities, we should not proceed for DNE directly. If we have that facility, then uterine artery embolization should be done before, otherwise the risk of hemorrhage would be there.
Yes, ma'am. So as you pointed out, uterine artery embolization was done in a setup followed by suction evacuation the very next day. So uterine artery embolization, as ma'am, would you like to add about uterine artery embolization?
Of course, this is a procedure which can be done by interventional radiologist only, and all facility may not be available everywhere except in bigger centers. But yes, it is a useful procedure in such a stable patient, such cases, and or in gynec cases. These are the other indications. It is always indicated in a hemodynamically stable patient, and other indications are fibroid or even this choriocarcinoma, and the procedure is done under radiological guidance, where gel form, particles are injected through the femoral.
Yes. So Dr. Divya ma'am is not here. So Haresh Doshi sir, what are the indications of uterine artery embolization? Your experience, if you would like to share with all of us, complications, all an outcome for future fertility.
Only few cases we have resorted to this. As I told you, in our neighboring institute, it was just walking distance. And the patient, because patients were stable, we could ship those patients, and all patient naturally stable patients. But this indication, they are increasing nowadays because of sonography. We are now diagnosing AV malformation. With beta HCG, we are diagnosing leucoplastic tumors or placental retained beads. But even in scar ectopic, other ectopic, which is uterine, not secondary abdominal, some cornu and all, there all when there is a maximum chances of bleeding, uterine artery embolization is suggested. Even Dr. Sadhana madam told that guidelines do not support, but even for past disorder, placenta acquired spectrum disorders, people have done this because the artery is not embolized, only catheterized. As soon as the baby is delivered, you inject gel foam or PVA particles and then proceed for cesarean section as well as hysterectomy. So that is right. Uterine artery embolization has its all problems apart from the availability, but it has a wonderful results also up to 70% of cases. Uterine artery embolization.
Very well said, sir. So it has a lot of advantages being non-invasive because surgical incision is avoided, GA is avoided, is very less blood loss, so risk of blood transfusion is also reduced, shorter recovery time, patients go the same day, and the complications of uterine artery embolization is what we are all worried about, but they are very less. Immediate complications are just the local ones which are associated with catheterization, the groin hematoma, the arterial thrombosis. Dissection is very rare and pseudoaneurysm, but the real, the most common complication is one which occurs within 30 days is the post-embolization syndrome. But it is a very mild syndrome with pain, nausea, fever, and malaise, and it has to be managed conservatively. Generally, is self-limiting in 10 days to 2 weeks. But what is worried about, sir, the second part of the question was that people are concerned that if she undergoes uterine artery embolization, what will be the effect of same on her future fertility? So, sir, if you want to add about this.
No, you are right. You are right. That is a bit not very well evidence-based proved. Okay? It will definitely problem, but that we don't go for when the patient wants child because of ovarian exposure. We don't choose as a first treatment. But the cases are there. There is not only this that patient have conceived, delivered, second time PPH, and second time uterine artery embolization was done. So for treating her, so that is not a right problem. Long-term infertility, fertility potential is not much, right? As you mentioned, all these studies, they're very well without adversely affecting the pregnancy.
Correct, sir. And it is also dependent upon the patient's age as well. So we must counsel that now we have enough evidence that even if she undergoes uterine artery embolization, she can conceive, but her health is more important, which has to be saved when a patient is there having PPH in postnatal period. So I would like to request Jyotsna ma'am to please summarize before we end the panel.
I would like to add, madam, in between.
Yes, Ina ma'am. Yes, ma'am.
With uterine artery embolization, this is there may be variants in the vessels also, and this is non-selective embolization.
Correct,
so sometimes definitely the course of uterine or vaginal and wherever the dye goes. So this is also tricky for interventional radiologists also if there are variants. So if the artery, if we are embolizing uterine and the division course of the uterine is somewhere, division is at different place, then there may be a problem.
Yes, ma'am. So misembolization can occur if there are.
You are right, Dr. Singh, you are right, but we have witnessed that, and we were there in the radiology institute there. Immediately you can see the blood was going from whatever, because anatomy of every individual is different. You are right, vessels may be different, but as soon as he injects the right PVA particle, immediately the blood distal to the vasculature, you can see on the TV screen, and you are satisfied there. Patient vitals may not improve, but you are satisfied that now the bleeding is stopped there.
Sir, that is true, but what they say is that the same arterial may be supplying to bladder or maybe supplying to rectum path that they explain to the patient. I also witnessed many of the embolization procedure at our institute, but they still explain them rare in 1 to 2% of cases. The things can happen.
Yes, yes. Every intervention does have a flip side, and definitely whatever has got good effects can also have the side effects. So there is no doubt about it, but it is a very useful modality. We had put this case only because we know that it is not available everywhere. But for this particular case, which came to our hospital, she had got previous 3 miscarriages, and this was the only live fetus, a live baby, which was also preterm, and it was in nursery. It was a sick baby. So we were trying to save her uterus, and therefore, we took all these measures. And as sir said that, future fertility, we are not sure, but then we don't have anything much to offer also, because in this case, when she's come with secondary PPH and she is having this kind of picture, they were vascular RPOCs and the AVM, there was a confusion between these two. So the vascularity was so much increased, but then we went in for the UAE, and after that we did the suction evacuation, and we could save her uterus. Of course, we are following to see whether she will be able to conceive and have a normal pregnancy, later on. So, Shiba, you can show the summary slide. So, we would just like to conclude this session. I think all the important points have been discussed, and the difficult kind of cases. One was the medical management, one was traumatic PPH, and this patient in whom we had to do a uterine artery embolization. So all these cases have been discussed, and important here is, again, I would like to say the golden hour is pivotal. Early recognition management is essential through, there is a hemostasis algorithm also, which the PGs can learn. So anyway, we are now short of time, so I don't want to go into the theory part, but I would just like to say that recognition, the 3 R's, for PPH, recognition, availability of the resources, that is the second R, and the appropriate and quick response, that is the third R. So recognition, resources, and response. Remember that if we have to save the life of the patient, we should, think of these 3 R's. And for that, one very important thing is to do the drills. So Dr. Shiba had shown the pin girl, and we routinely do these kind of drills for our PG students, so that when these kind of emergencies arise, they don't have to think, what is my next step. So because the quick response can save the life, And at that time, if you have not done drills, everybody is, running helter-skelter. What should I do next? And, not do the things in an organized way. So that's all I would like to say. Shiba, you can, this is the most colorful slides prepared by Dr. Shiba, our young associate professor. So really appreciate the beautiful slide, Shiba. Thank you so much.
Thank you, ma'am.
We really wish to thank all our expert panelists and our expert for being here with us today evening and giving so many insights into these difficult cases. Thank you so much. Dr. Sadhana, over to Dr. Sadhana. Yes.
I would like to thank Dr. Sadhana and Dr.
Yes,
Joseph,
please.
Dr. Shiba, everybody for a wonderful panel discussion.
Don't thank, also give votes. Don't thank only, also give votes.
Dr. Doshi's that tip was very good about giving a slight, push to the fundus. And Dr. Samarth also said that when you put the cannula and then, if you just give a slight tug, you will see the whole cervix nicely.
Yes, yes.
I think those tips are really useful.
So thank you very much, Dr. Jyotsna, Dr. Shiva, for a wonderful panel and a very, very good discussion. Dr. Haresh Joshi is known for his teachers of teachers, and he has such a good sense of humor that we learn difficult thing very, very easily. So
thank you, madam.
Thank you, Dr. Haresh, for giving your precious time and precious pulse of wisdom. And we learn so much things like a varied experience of uterine artery embolization, and always skill is with us, and the resources, like it can be varied. So intelligence is for everyone, and here we are together. So a great thank you for Rajkot, Bhuj, Ramnagar, Bharuch Society, and all the 5 society. And again, thanks for being together. And we look forward for such association, worthy association from all parts of country, because that gives us the sharing of experience that what we can do. We can recommend Samartha Ram cannula for everyone. Few questions are there which I tried to answer. One was that if while Samartha Ram is not there, but Dr. Haresh is with us, why you are using the 2 cannulas in cesarean section. So my answer is that the smaller cannula gives easy access to the cervical canal. A bigger one to this, and then we connect to the suction cannula. So Dr. Haresh, your comment that
because the people were finding difficulty in passing that suction tube, he devised that. When he came to our place 4 years back in my hospital, he demonstrated a cesarean section. At that time, he was not using it. Now he has come up with. This is very good. It is just to thread the cervix. Normally, we dilate in elective cesarean section. We may or may not dilate the cervix from above with finger. So that time you have to, rather than easily, you can a solid instrument. It is not a flexible tube. So solid is cannula. You can anything. It is not a anything you can pass on the suction tube. Like any stiff thing, you have to negotiate the cervix and come out of the vagina, so that you can hold and don't introduce a finger in the vagina where chances of infection is there. Only for that purpose.
I answered the same, so that was just common sense. I answered that it
common
is easy to insert. It is the basic surgical principle. And one question that
I am here.
Samartha, for you,
yes.
he says if the SR cannula is not available, though Dr. Samartha is with us to provide, then can we do the holes in the plastic suction cannula? So
you can improvise. You can improvise in the same suction tube. You can make holes and put inside and create negative pressure. It works.
So great. So yes, that's I say yes.
See,
but
sometimes
your cannula has got different diameter for the fundus and different diameter for cervix. That is the lower cannula beauty. But of course, that was a question.
No,
and third was
I'll answer in a better way. The cannula, we have given a larger diameter so that it should not get blocked. Your suction tube will have only 1 centimeter diameter. When the massive bleeding is there, it blocks. That's the reason we have designed. Hello.
One question was for Dr. Nalini, then Dr. Harish will just how to rotate the easy balloon. That is a condom balloon tamponade. So what Nalini says that it is nothing to rotate, it is insertion and removal. So Dr. Harish, your comment about it.
Yeah, it is not.
Need the rotation of easy balloon like balloon.
No. When you pass it inside, if you do not negotiate only at that time before inflating, but after inflating, you don't have to rotate. You don't have to rotate. And there are two types of balloon tamponade. One is a fixed volume and one is a free drainage balloon. There are numerous balloons now available. As I mentioned, in USA, now that is a JADA system. It is a silicone made, very nice device. But that is a suction. That is a suction. But other thing is there, that is ESM balloon, Dr. Cooper's. So that is same thing. You don't have to rotate it. And Bakri balloon now, like this Dr. SR Cannula, Bakri balloon is modified. They are doing both balloon as well as drainage, suction, negative pressure. Both they are using. Modified Bakri balloon is now available. Modified Bakri balloon. Not only balloon tamponade with negative suction. They are combining both the methods. So that is now available. I think I would request Dr. Jyotsna Madam and Siba Madam to put the answer wala slides on the group. You have put the questions on the group. Now your answers, and I was going through it, very nice, complete answer. So please put that PowerPoint also in our group so that we can.
Definitely, sir. Thank you for the appreciation. We'll put the entire PPT in the group.
Yes, that is good.
Thank you, sir.
Thank you, madam. Thank you, Sadhana madam.
Is left, so my pleasure duty to deliver vote of thanks. So thank you, Rajkot, Jamnagar, Bhuj, Godhra, Bharuch Society, and I extend my request that please do invite me in the personal physical CME. So it will be great pleasure to be with so good expert and the experienced people. My thanks to Dr. Alpesh Patel, Dr. Chintan, Dr. Heral Pandya, Dr. Sunil Patel, Dr. Bhimani Pandya, Dr. Radha Nita, Dr. Varsha, Dr. Jigna, Dr. Nita, and Dr. Pravesh for all the coordination and for all your hard of it. And Dr. Jigna was so concerned, and we were in constant touch that how to design the flyer. So that makes us also motivating. So it is just a beginning. It is a beginning of association with new friends, and we are all together with our dedication to save every lives everywhere. So thank you very much. Good evening and good night to everyone.
Good.